Laryngology, head and neck surgery. We at Abbott, being a scientific company, believe in constant knowledge sharing and learning, and doing multiple differentiated program presently as well as in have done multiple program in past to understand to share different recent advances in the respiratory medicines. We have done various online courses. We have also done various webinars, CMEs, and workshop. Like recently, we have done with Professor Valerie. So thank you so much, everybody, for joining us today. In continuation with our constant aim of knowledge sharing, today I really welcome all of you in this live ENT virtual surgical surgery workshop. This is a series of workshop. Today we are having the first event and we'll be having the second event in coming months. Today, in 1.5 hours, we will be discussing about endoscopic sinus surgery, wherein we will be having two surgical session with very renowned speaker of the country, Dr. Satish Jain and Dr. Neelam Vaid. We have Dr. Nishit Shah. He will be moderating the event today. We'll be having the panel discussion wherein all the panel members will be answering the questions. So I request all delegates to kindly post their questions in the question ask the question tab in these on the screen below. You can also, after the completion of the event, click on the next button and you will find the multiple choice questionnaire on your screen, and you can answer these questions, and 70% of the correct answers will be eligible for the certification from IAOHNS. So before we begin with the event, I would first like to welcome Dr. P. Vijaya Krishnan. He is the Secretary of IAOHNS, consultant at Madras ENT Research Foundation, Chennai, Head of Department of Snoring and Sleep Apnea. He is well trained in all basic and advanced ENT and headache neck surgeries at Madras ENT Research Foundation, Chennai. He is special training, surgical training at Euroclip Sleep Clinic, Norway. He has well trained in surgeries of snoring, sleep disorders, cochlear implant, etc. He has delivered multiple guest lectures and multiple publication to his credit. So, on behalf of everybody, I would like to welcome Dr. Krishnan. Thank you, sir, for joining us. We also have with us the global icon, the very renowned ENT surgeon of in our country, Dr. Mohan Kamishwaran. He is a chairperson for IAOHNS, Managing Director, Chief Surgeon at Madras ENT Research Foundation, Chennai. Honorary Professor, Mahatma Gandhi Medical College and Research Institute, Pondicherry, India. He has received Padma Shri Award in 2006 from past President, late Dr. APJ Abdul Kalam. He has visited as a guest faculty and professor at Ed Hill University, UK, and University of Pennsylvania, USA. He has invited as a guest speaker for various prestigious global forums like WHO, Royal Society of Medicine, London, and American Academy. He has also 200 plus publication in major international journals, as well as have various chapter published in textbook. So on behalf of everybody, I welcome Mohan Kamishwaran sir. Thank you for joining us. It is our privilege to have you. Now I would like to hand over the event to Dr. Mohan Kamishwaran sir to give a welcome note and the context of the event. Thank you, sir.
Thank you. Thank you, Dr. Zenifa. I think it was very, very kind of you to introduce us first. I would first of all like to thank Abbott for partnering with the Indian Academy of Otolaryngology and Head and Neck Surgery for bringing out this massive program today. It's something which we've all been looking forward to for quite some time. The word symphony indicates a confluence of beautiful music, and that's exactly what we have today. We have three maestros who are all absolute global names and who are bywords in this particular field. And to bring these three maestros together under one roof, I think it's a tremendous effort for which I thank the president, Dr. Handa, the dean, Dr. Naresh Panda, and secretary, Dr. Vijaya Krishnan, and for Abbott for partnering with them, with Indian Academy to make this happen. I don't want to take more time, but I want to briefly say that these three names, I mean, I'm supposed to introduce them, but I think it will be extremely superfluous on my part. But suffice to say that Satish is the director of Jain Hospital. Dr. Nishit is a consultant at Bombay Hospital and at Breach Candy Hospital. And Neelam, of course, is in KEM Hospital in Pune. And all these three people have really put the field of endoscopic surgery in a global map, on behalf of the country. And it's quite appropriate that IAOHNS has asked them to, take us through the steps of this fascinating field. I think Satish Jain will be starting with trying to inculcate us the basics of the anatomy, both endoscopic and radiological. And then Dr. Neelam will be giving us the tips and tricks in surgery. And of course, the wise man Nishit will be moderating the whole thing and trying to put some sense into our heads at the end of it all. So I wish them luck. I'm certainly looking forward to this great anticipation, as I'm sure thousands are. And we'll really have the final tally at the end. But I know everybody is looking forward to this event and to these three great maestros. So all the best. Thank you for sparing your time on behalf of the Indian Academy, on behalf of the president and the dean and the secretary. A big thanks to all of you for taking your time out on a Sunday evening. So please, with that, I ask Vijaya Krishnan to take over proceedings from here.
Thank you very much, sir. Yeah, I would like to request Dr. Shah to moderate the session without wasting further time. Thank you.
So thank you so much, Vijay and Mohan, for your kind introduction. Dr. Satish Jain from Jaipur, international ENT surgeon. He's going to be actually talking to us on the cornerstone of FES, which is anatomy. And of course, you know that anatomy is for FES partly based on the understanding of the CT scan, which is your roadmap towards surgery. So this is really important because I think 1/3 of your surgery is done on the scan even before you enter the OT. And then you do the remaining surgery in the OT. So over to you, Satish, for your talk.
Thank you, Nishit. Rather, at the outset, I would like to thank the Indian Academy for giving me this opportunity to be part of this session. And big thanks to the big man, the Master Blaster, Dr. Mohan Kamishwaran, and Dr. Vijaya Krishnan, of course, for giving this opportunity. And it's a pleasure to be part of this event with Nishit, the big endoscopic surgeon we all know is a renowned skull-based surgeon in Mumbai, and Neelam, of course, who's doing wonders with a lot of work. Thank you so much once again. Am I audible?
Yes, very much.
Yeah. So coming to the topic assigned about the anatomy of the paranasal sinuses, like Nishit has already emphasized in nutshell, anatomy, and most of the job is done if you are through with the three-dimensional anatomy of the area where you are working. So for the paranasal sinuses particularly, anatomy is very important. The reason being, the paranasal sinuses are in close proximity to the orbit and the skull base. Even a millimeter, margin of safety sometimes is bothersome. So margin of safety overall is very less. You have to be very accurate and you have to be very diligent in while working along the skull base, along the orbit. And that comes through your understanding of the anatomy of that particular patient. So like Nishit mentioned, CT scan is important, of course. So what kind of CT scan we order and we should order at the beginning when patient comes to us? Our philosophy is to order a fine 5.5 to 0.6, 0.7 mm according to your machine capacity. Axial sections, that is almost a 20 centimeter area we are going to scan right from top to bottom, from the brain to the bottom of the paranasal sinuses in the axial sections. CT scans are always shot in the axial section, and we should acquire in the DICOM format, and then through our software we can reconstruct them to all three planes. This is important to understand three-dimensional anatomy of the paranasal sinuses, and that gives us complete information rather acquiring CT scan in one or two planes, that too in limited number of films, and that too not having a dynamic scenario of anatomy in your hand. So most important is to have a dynamic anatomy, that too three-dimensional, and that is a complete information of the paranasal sinuses of that particular patient. To have complete information, what I mean to say complete information means we should be able to see three-dimensionally not only the paranasal sinuses but the surroundings as well. We should be able to correlate the surrounding relationship in 3D manner. That's what I am going to emphasize over here. So like this particular patient, the CT PNS was shot in axial plane, and I am reconstructing through this DICOM software into all three planes. And here, believe me, it makes your life easy for the beginner to understand CT scan much better. Like for example, if I am looking at some cell in the frontal sinus on the same plane in which we operate. So for a particular anatomy in the coronal section, we can see relationship in all three planes in axial and coronal. We take our cursor to that particular region. Like this is the beak. See, you can see the beak well in all three planes. Anything you want to see in any plane, you can take your cursor, and that is what the dynamic anatomy is. That is what we want to see. That is what the information which is most relevant surgically if we have. So we should order the CT scan in fine sections in axial plane and reconstruct in all three planes, and sit with the CT scan for a while to understand the CT scan in detail. Because we all know for sinus disease, for operating on the sinuses, we order the CT scan mostly not for the diagnosis. Diagnosis of this disease is mostly clinical on the basis of symptomatology and clinical findings. CT scan is useful mostly in clarifying the extent of disease, and most importantly, at the end of the day, in planning surgery and minimizing complication. So when we order a CT scan, it should be multi-planar in dynamic, as I said, in the DICOM format, and we should see with the CT scan for at least 20 minutes to see each and every aspect of the anatomy of that particular patient of the paranasal sinuses. And we should like have a checklist or something so that we don't miss anything which can be clinically useful, and all these things are important in minimizing complication. The bottom line is minimizing complication by means of understanding three-dimensional anatomy. The reason is very obvious. Like I mentioned, the margin of safety is very less. Sinuses are in close proximity all around with the orbit and the skull base, and a millimeter difference can make the difference, in terms of outcome. So all this is just a basic outline of the checklist, what all we should be reading in a CT scan of the paranasal sinuses in detail. Everything is important to be seen in detail. Like for example, the cribriform plate. See, as I said, we should be looking at the cribriform plate dynamic. There are variety of cribriform plate scenarios which one can come across, from a shallow to the deeper one, like Kiros described from type 1 to 3. And this is clinically relevant. And we can get this information pre-op from the patient, CT scan, that particular patient, what kind of cribriform plate the patient is having. Like for example, in this particular patient, if we go, how do we look at the cribriform plate, and what is cribriform plate? Cribriform plate is a part of the, a bone making the floor of the olfactory fossa. See, this is the part of the intracranial fossa, and this is the olfactory fossa, and this is, guarded below by the cribriform plate separating from the roof of the nose. And this cribriform plate is lying at a lower level than the level of the paranasal sinuses. Look at how high are the paranasal sinus cells as compared to the cribriform plate. And while working in close proximity to the cribriform in the paranasal sinus, in the roof of the anterior group of sinuses, one has to be very careful in dealing with the cribriform plate. By means of your radiology, you can actually gauge that how deep is your cribriform plate, how it is related to the paranasal sinuses, and this is important when you are working in close proximity to the frontal recess. See, these are frontal sinuses. How do we read the CT scan in short? See, if I come from anterior to posterior, this is frontal bone. Frontal bone, this is nasal bone. This is frontal bone. This is pneumatized frontal bone. This pneumatization coming from anterior to posterior. I am going anterior to posterior. This is roughly the intersinus septum. This is a complete intersinus septum. See this? Then comes the incomplete septation. As I go behind, this is intersinus septum. Some cell is coming in the right frontal sinus, but still it is frontal sinus. The reason is the floor is still intact. The frontal sinus, if I go from anterior to posterior, look at this. If I go from anterior to posterior, the entire floor is formed by this thick bone. And frontal sinus drain behind, not anteriorly, they drain behind through the frontal recess, and this is the frontal recess. We should be looking at the CT scan dynamically, how the frontal sinuses are draining into the frontal recess. And at this point of time, while working in the frontal recess, the cribriform plate is in closest proximity to the surgical tools, and this is where we should be knowing how deep your cribriform plate is, how cellularity is there in the close proximity to the cribriform plate. And with your software, you can actually gauge the depth of the cribriform plate, the olfactory fossa. How deep is the olfactory fossa, you can see very well. You can measure in millimeter, and that is really useful in terms of gauging safety to the particular situation. And in this situation, see, this is the nasal septum. You can see the entire deviation of the nasal septum, and this is continuing intracranially as a crista galli, which is actually a extradural structure. This is olfactory fossa, and at this point of time, most anteriorly to the cribriform plate, it has two parts, the horizontal and the vertical lamella. This vertical lamella continues with the frontal bone, making the floor of the intracranial fossa. So this is the lateral lamella, which is most important for the surgeon. This is the thinnest part of the skull base in this region, and if somebody happen to hit this lateral lamella, can lead to a disaster, giving a CSF leak. And that's why Neelam will emphasize more during the surgical part. I'm not covering the surgical part. And see, when surgeon is working in this region in the frontal recess, is always advised to direct the instruments laterally to avoid injury to the cribriform plate. So that is the area of most concern to the endoscopic surgeons, and that is how you can read very well endoscopically that how difficult your life is going to be. And see, at this point of time, the most important anatomy, which is here to the endoscopic surgeon, which always keep you oriented, is the middle turbinate. This middle turbinate is one of the most important anatomy for the endoscopic surgeon, and this turbinate has three parts. See, now I am coming again from anterior to posterior, and see the beginning of the middle turbinate. This is the beginning of the middle turbinate, and what is happening? This is the first vertical segment of the middle turbinate. Middle turbinate is a three-dimensional structure. This is the first vertical part which is attached to the cribriform plate up there at the junction of horizontal and the lateral lamella. And as we go behind, see this turbinate, what is happening to it? This is turning laterally. This turbinate is turning laterally to insert on the lamina papyracea. And that is the point we should know intraoperatively, as well as all these cells anterior to it are anterior ethmoidal cells. All the cells behind are posterior ethmoidal cells. See this turbinate now is taking a turn. This turbinate is now taking a turn. That is the ground lamella. And as we go behind, that is the second part of the turbinate, which lies in the coronal plane. You can see and as we go behind, this turbinate goes continuously. Keep an eye on this. This goes continuously behind. This is the sphenoid sinus, nasopharynx coming in right up to the roof of the nasopharynx here as a third part in the axial plane. So this turbinate is a very, very important step in anatomy to the endoscopic surgeon, and we should always try to preserve the turbinate while operating in this region to keep yourself oriented. Reason being, while walking in the frontal recess itself, if you lose orientation and go medial to the turbinate, see what is there. If you go medial to the turbinate, one can easily hit the skull base above. So that's one of the most important anatomy. As you go behind, this turbinate is important for the reason that this is the transition between the anterior and the posterior group of ethmoidal cells, and we should be knowing this fact while doing sinus surgery, as all anterior group of ethmoidal cells are draining anterior to it and all posterior group of ethmoidal cells are draining behind it. See, the movement of middle turbinate go from anterior to posterior, the superior turbinate comes in the picture. This superior turbinate, as compared to the middle turbinate, it's attached to a flat roof. See this? There's a thick posterior ethmoidal roof as compared to the middle turbinate. See, this middle turbinate was attached to the thin anterior ethmoidal roof and to the cribriform plate. And even the slightest manipulation of that middle turbinate right here close to the cribriform can result in CSF leak. As compared to the superior turbinate, see this, which is attached to a thick posterior ethmoidal roof, and here that is something unlikely to give that kind of a complication if you manipulate the superior turbinate here as compared to the middle turbinate. And here all these cells, once you see the superior turbinate completely, what you see, all these cells in relation to the superior turbinate are posterior ethmoidal group of cells. See the, look at the orbit as you go behind. See anteriorly the dimension of the orbit, and as you go behind, the dimension of the orbit is reducing. The large cells are appearing. These are posterior ethmoidal group of cells. And as you go behind, see what is happening to the septum. The septum is, see the septum was right from the top to the bottom. The right from the posterior ethmoidal roof to the floor of the nose. And as you go behind now, as we go behind, now the septum is no longer attached to the roof. The septum is limited right over here, and new pneumatization is coming as you go behind. This is the rostrum of the sphenoid sinus, rostrum of the sphenoid bone, and this is the sphenoid sinus coming in. See how dynamically we can see, like we are operating upon the paranasal sinuses. You can look at the CT scan in the same way. And as you go behind, no more septum. This is choana, this is sphenoid sinus, intersphenoid septum. So the point is, your radiology can take you like a virtual journey of the surgery. If you have a good, see this is 0.4 mm CT scan. You can't miss anything beyond a less than 0.4 mm, from your visualization. So each and every possible thing is there, and you can plan your surgery accordingly. Like for example, see all these complications once come to your attention, it is the surgical anatomy which is most important tool for the prevention of complication. Like I mentioned, for the cribriform plate and the CSF leak coming behind. See, this was sphenoid, the frontal sinus. All these cells bulging into the floor of the frontal. See, this was beak, the beginning of the frontal recess, and this frontal recess is narrowed by group of cells. These are agar cells, and what you can do best for this agar cells, that is the most important part of the surgery in this region. Once you come across, see, these are agar cells. What are agar cells? Look in the sagittal sections. Look in the sagittal sections. That is the best section to give you the detailed information of the agar group of cells. See, if I take the sagittal section in consideration, what I mean to say here is, see, this is the frontal sinus draining into the nose. That is the beak. And there are some group of cells lying in the frontal recess region, narrowing the frontal sinus outflow drainage. So what you can see, there are certain group of cells attached to the anterior wall. Anterior wall is beak, and there could be certain group of cells attached to the posterior wall. So these are anterior wall cells, most often encountered, almost always encountered, are the Agarnagi cells. And what you can do, you are coming with your instrument from here, and for the frontal sinus, particularly with a 70-degree, you can use your instrument behind. Push your instrument behind the Agarnagi and take these cells anteriorly out, and you can widen the outflow of the frontal sinus very, very easily. So depending upon the anatomy of the frontal recess, you can actually take your call that what kind of cell is this and how to tackle this to improve your frontal sinus outflow. So everything depends upon the CT scan. So your frontal sinus work totally dependent upon the CT scan with the help of sagittal and the axial section, that how to look for those particular cells, narrowing the outflow, sinus outflow drainage, and how to overcome those situations. I will give you certain examples for your easier understanding for the frontal sinus, particularly here. See this, what I mean to say, the frontal recess cell, there are certain group of cells which are attached to the anterior wall of the frontal sinus outflow, that is anterior to the drainage pathway, and certain group of cells posterior to the drainage pathway. So anterior cells are Kuhn type 1, 2, 3, 4 Agarnagi cells, and posterior are suprabular, frontal bular, supraorbital. All those group of cells are behind. See this, you saw this Agarnagi. Just go behind that Agarnagi and get that out. That's it. That's it. Nothing else is required to be done. See the huge Agarnagi sometimes number of cells in this region, and there are cells above the Agarnagi. If you have a good CT scan, dynamic sagittal section, you can actually see this is your frontal sinus, and number of cells are blocking the drainage. And in the same way, if they are attached to the anterior wall, go behind them and get them out. That is the simplest way. Sometimes see the tier of cells, number of cells. If you don't have a good CT scan, good sagittal section, you can actually miss, and one of the large cell may look like a frontal sinus itself. That can mislead you to the frontal sinus, and then you can't expect a good outcome. So look at the CT scan thoroughly, look at the tier of cell. Again, the sinus is above there, and actually all these cells are attached to the anterior wall, and yet again you can go behind them and get them completely out to widen the frontal sinus outflow. So the cellularity is where the cells are attached. Depending upon that, you can clear them. If the cell is attached to the posterior wall, you can't afford to go behind that and fracture that out. Now this is one of the most difficult situation. Type 4, isolated cell or cells high up in the frontal sinus. See, if the cell is so high up there, you have to go high up behind that cell and get it out, and coming from there, the biggest obstacle is the beak. And most of the time for such type 4 high up cells, you have to drill away the beak by means of draft procedures. Depending upon the situation, you can choose draft 2, 3 and variety of drafts to reach that cell, see that cell completely, go behind that cell and get the cell out. So again, it depends upon the radiology to give you that visualization, that what kind of anatomy and the pathology you are having in that particular cell. These are posterior group of cells, suprabular cells, sometimes frontal bular cells, and you can actually identify supraorbital cell. You can actually identify from the CT scan that what kind of cell in the particular patient we are having. Now, what is supraorbital? That's a very common anatomy we encounter. See this, very simple. This is your frontal beak, and what about there is the frontal bone, and what these two big are the frontal sinuses. Now keep an eye on the floor. As long as we are going behind, as long as the floor is intact, that is frontal sinus. Now the floor has gone, the frontal recess has started, the cribriform plate has come in picture, the crista galli, and see what this pneumatization above the orbit. What this pneumatization above the orbit looking like frontal sinus, this cannot be frontal sinus. It is as simple as that. When you see the cribriform plate in picture and this pneumatization above the orbit, this can be huge. We have seen this supraorbital pneumatization even up to the zygoma with pathology in it. with purulent secretions in those cells. So this is supraorbital pneumatization, supraorbital cell, and with a cribiform plate in picture, whatever kind of pneumatization looking like frontal sinus, this cannot be frontal sinus, this is supraorbital cell. And another guide is the maxillary sinus. See, the supraorbital anatomy is behind the frontal sinus. So when the frontal sinus disappears from anterior to posterior, you have reached posteriorly to the level that your maxillary sinuses have come into the view. So now if I come back anteriorly, see now frontal sinus, you can't see the maxillary sinus. Your floor is intact, frontal sinus. Now the floor has gone and now looking like frontal sinus. This is supraorbital cell, and what you see the maxillary sinus and the cribiform in picture, it is 100% supraorbital cell. And once you have a supraorbital cell, you have to be careful for two reasons. One is to widen the frontal sinus, as this pneumatization may narrow the frontal sinus pneumatization anteriorly, and second is more and more pneumatization the skull base at this level make the anterior ethmoidal artery more and more prominent. See now what I mean to say. Another important thing surgically for our junior colleagues, see the supraorbital pneumatization is an important guide to the anterior ethmoidal artery. I am coming from anterior to posterior. This anteriorly frontal sinus, then the frontal recess, supraorbital cell, yet we are in nowhere close proximity to the anterior ethmoidal artery. Now as I go behind, see the anterior ethmoidal roof, as I go behind, where the supraorbital pneumatization ends, supraorbital cell ends, as we go posteriorly, is the cribiform, is the anterior ethmoidal artery coming to the picture. See this, that is the level of the anterior ethmoidal artery in the posterior most part of the roof of the anterior ethmoid. See, anterior to this is posterior. I am not, see how posterior it is, see now anterior. This frontal sinus, frontal recess, cribiform plate, now the supraorbital pneumatization, everything ending, and now behind is the anterior ethmoidal artery, and you can see this beaking of the medial part of the orbit transmitting this canal, that is the orbitocranial canal, from the orbit to the anterior canal fossa. This is orbitocranial canal transmitting the anterior ethmoidal artery, and this gives you a very useful guide in the coronal section that above the level of the anterior ethmoidal artery, how high the roof of the anterior ethmoid is. There is pneumatization above the level of the anterior ethmoidal artery, and that could be, this anterior ethmoidal artery could be hanging in the mesentery. The bone is not very thick. More the anterior ethmoidal skull base is pneumatized, more are the chances of this artery being running in the mesentery, and that is one of the most important guide to the surgeon to stay careful in this region while dealing with this artery. This region with the artery in vicinity, to avoid injury to this artery and injury to the skull base as well. So how the anterior ethmoidal artery is running, how the skull base is in relation to the anterior ethmoidal artery, whether it is in mesentery or not, the relationship with the skull base. Now as I go behind, see this artery, I am going behind the level of the artery now, and see what is suddenly happening. The ethmoidal roof, which was earlier like this, the cribiform plate, thin roof, has completely changed to the thick post-ethmoidal roof. That's a very important thing. See how you can relate surgically that the anterior ethmoidal artery, which was running in the roof of the anterior ethmoid, once you look at the anterior ethmoidal artery and just go behind, few millimeters behind the anterior ethmoidal artery, is the post-ethmoidal roof starts. That means the anterior ethmoidal artery runs through the posterior most part of the anterior ethmoidal roof, and then as you go behind that, the posterior ethmoidal artery, the posterior ethmoidal roof starts, and the differentiation. See, the differentiation between the anterior and the posterior ethmoidal cavities is the ground lamella, and see this is the level of the ground lamella. So for the differentiation between the anterior and posterior ethmoidal roofs, your guide, the most important guide, is the anterior ethmoidal artery, behind which the posterior ethmoidal roof starts, and just behind that is the level of the ground lamella. So in order to enter into the posterior ethmoidal cells through the ground lamella, that is the point where you need to look at remove all the cells anterior to it, and then enter into the post-ethmoidal cells. And then you see the post-ethmoidal cells coming, which is lined medially by the superior turbinate all the way. This is like a box where the orbit is laterally, superior turbinate medially, roofed by the thick post-ethmoidal skull base, and then and then as you go behind, the sphenoid sinus starts. Now, the same point, at this point of time, one of the most important anatomy for the maxillary sinus work is the infundibulum and the osteometal complex. What is osteometal complex? This maxillary sinus opening opens into thin, narrow channels of the anterior ethmoidal cells. See this. This is the uh, uncinate process. This is the middle turbinate. This is the bulla ethmoidalis, and this is the maxillary sinus, which is narrowing to the infundibulum. And this space between this uncinate and the bulla, this hiatus seminaris inferioris, and then it opens in the nasal cavity. So this area is the osteometal complex, and the best way to define this anatomy, of the osteometal complex is reconstruct in all planes, come to the osteometal complex region, and then look in the axial plane. Axial plane gives you complete information of the osteometal complex. See why I'm saying this? Anterior to posterior. This is your nasolacrimal system. This is how your the infundibulum opening into the nasal cavity, and that is how one by one, this is your uncinate process, this is your bulla ethmoidalis, and how these narrow channels are there through which the anterior ethmoidal group of cells drain into the nasal cavity. That is how one can easily see by means of all these planes have their importance in giving you the in-depth knowledge of the anatomy of that particular region. So uncinate process, if you want to look at, see this uncinate, how it is going up, going up, going up. It merges with the medial wall of the agar cell here and get most of the time inserted on the lateral wall, laterally onto the lamina pepracia. See this uncinate again, uncinate going up, where my cursor is going up and merges with the medial wall of the agar cell to get inserted into the lamina pepracia, giving us a medial drainage pathway to it. See, that's the middle turbinate, that's the uncinate process, and in between is the medial drainage pathway. If this uncinate in an uncommon situation happens to get inserted onto the onto the middle turbinate, and then your pathway of the skull frontal sinus drainage is lateral to it, and then is a difficult, I would not say difficult, but some important information surgeons should have in mind to deal with this uncinate. Otherwise, breaking the uncinate or pulling it off can have an impact on the middle turbinate upper attachment and can even lead to a CSF leak. So this kind of information, where the uncinate is going, actually is best seen on dynamic imaging rather than the screenshots of the CT scan or the still CT scan picture. So dynamic imaging is most important to have complete information of this area as well. And you can see the infraorbital cell bundle, the infundibulum, hiatus seminaris inferioris, inferior turbinate. All this information you can get dynamically very well. Now, as we go behind, before I come to an end, this is the sphenoid sinus, and this is most important of all the paranasal sinuses in terms of margin of safety, in terms of giving complication if something happens untoward. The reason being, the sphenoid bone is surrounded all around by lots of important neurovascular structures. And if I go from anterior to posterior, see this bulge of the optic nerve in the roof of the sphenoid sinus, and this bone laterally with the process laterally, that's the clinoid process, the anterior clinoid process. And as if I go behind, that is the optic nerve, the clinoid that forms, if it is pneumatized, as the opticocarotic recess, and that's the bulge in the lateral wall of the sphenoid of the the paraclival carotid artery. And in the sphenoid floor, here, there is a canal on either side harboring the nerve, that is the Vedian canal harboring the Vedian nerve. And this is the pterygoid process on either side of the sphenoid floor, on either side, with two plates projecting downwards the median and the lateral pterygoid plates, and there are lots of, that's the canal for the V2 and other anatomy that is not relevant to the paranasal sinus surgery, but obviously we need to have a complete information about the surrounding anatomy as well in terms of preventing complications. Sometimes this is over pneumatized. We have seen this area sometimes so pneumatized that if surgeon is not careful, one can easily give complications. I will give you like this picture, like this. See, the sphenoid sinus is over pneumatized, and all the surrounding, neurovascular bundles coming in contact, the V2, the Vedian canal, everything lying in the cavity of the sphenoid sinus. So you have to be very careful with your sharp instruments or whatever instrument you are using within the sinus if you are dealing with the sphenoid sinus. This sphenoid septum, which is very important. See, the septum is here directed to the optic nerve. Sometimes the optic nerve is dehiscent, sometimes the carotid artery dehiscent. See the optic nerve prolapsing into the sphenoid, and sometimes the carotid artery. See the carotid artery on both sides, and here the carotid artery is prominent, and here the carotid artery on both sides, and here the carotid artery is actually projecting in the sphenoid cavity without any bone over it. So we should be very careful in dealing with all these situations, keeping the three-dimensional, all detailed information of the CT scan in our mind. Nishit, please feel free to stop me if I overshoot. I don't know how much time I have taken. Can you hear me, Nishit?
Don't worry, Satish. You can carry on.
So how much time do I have? I know I must have 2 minutes, 5 minutes, whatever.
Yeah, take 5 minutes.
Okay. So what I mean to say, CT scan is one of the most important way of acquiring three-dimensional information in relation to the paranasal sinuses, anatomy of the paranasal sinuses, in terms of having complete information about the extent of disease and the surrounding area in terms of safety. Safety is very, very important. Like this picture, see in the sphenoid sinus. This sphenoid, what I mean to say, this is the one of the most complex bone in the skull, the sphenoid bone, with its greater and lesser wings and the sphenoid pneumatized sinus in it. And see the endoscopic picture. In endoscopy, what you see is a lot of prominences within the sphenoid sinus, and all these prominences become more important once this is over pneumatized, making all these structures dehiscent. So while walking within the sinus, see, when the Stamberger introduced this concept of functional endoscopic sinus surgery, was mean to say establish the sinus outflow, the drainage, the ventilation and drainage, and expect the sinus inflammatory disease to revert back. Same exists for the sphenoid as well. If you have inflammatory disease you are working for, do not use any sharp instrumentation within the sphenoid sinus. Widen the sphenoid ostium. Look inside. If you want to suck or do anything, use blunt instrument and come out and allow the inflammatory disease to settle down. Similarly, for the radiology, this Onodi cell, one of the important anatomy, we always discuss this. What exactly the Onodi cell is? See, this is the sphenoid sinus. This is the left sinus cavity. This is post-ethmoid sinus. So what we generally do, first we do anterior ethmoidectomy, then go behind the ground lamella for the post-ethmoidectomy, and then behind the post-ethmoid we expect the sphenoid sinus. But this is not always true. As you go behind the post-ethmoid, sometimes the anatomy is different and the sphenoid is pushed rather posterior inferiorly, and what you see behind the post-ethmoid as you go behind, this optic nerve, which normally runs in the posterior lateral wall of the sphenoid sinus, run in the posterior lateral wall of one of the post-ethmoidal cell which has overgrown beyond the sphenoid sinus. And if you happen to go behind the post-ethmoid to look for the sphenoid sinus, one can easily injure this optic nerve. And this situation you can predict very well by means of all planes of CT scan, whether axial, coronal, sagittal. We generally see axial most often or coronal most often, and what you see in the coronal section at this point of time, this post-ethmoidal cell which has grown beyond the grown beyond the sphenoid sinus, like you see in the sagittal plane, and in the coronal plane, what you see the horizontal septation in the sphenoid sinus, for which the above part of the septation is the onod cell. And once you have onod from your CT scan picture, you have to be very, very careful, and in preventing damage to the optic, now in preventing this disaster. See, this is the picture from Stamberger book. This is the posterior ethmoidal cell which has overgrown beyond the sphenoid sinus. What a beautiful picture. The optic nerve, which normally lies in the lateral wall of the sphenoid, here comes to lie in the lateral wall of the posterior ethmoidal cell, that is called onod cell. And this is a very, very important anatomy we should keep in mind. In case this is there, we should keep a path. What we suggest always, once you enter the post-ethmoid, take a medial path. Medial path, you can take partly the superior turbinate, the inferior part of the superior turbinate, to look for the sphenoid ostium, and work close to the nasal septum for the sphenoid ostium, irrespective of the onod cell scenario. Even if there is onod, you are not likely to damage the onod cell if you are taking a medial path, rather than going straight away behind the the posterior cell to enter into the posterior into the sphenoid sinus. This was regarding, I have already mentioned about the turbinates. This is amazing. You can see three-dimensionally from your CT scan. About we should be able to see in all patients the middle turbinate, all three parts, the osteometal complex completely, to avoid any complications. So this is all about, in brief, the anatomy of the paranasal sinuses. Some radiological correlation in relation to the surgical part. I know the surgical details will be taken up by Neelam in detail. So I will limit my discussion here to this part, to hand over to Nishit and then Neelam. Thank you very much for your attention.
So thank you, Satish, for an absolutely fantastic presentation. Very good comprehensive coverage of all the aspects of the CT scan. And again, emphasizing the importance of doing a triplanar scan. I mean, it's incredible that a vast majority of ENT surgeons still are doing a limited CT scan. And I cannot understand why they would do that, because the amount of information that you're losing out from not looking at axial and sagittal, especially as what Dr. Satish Jain explained, using DICOM images and 3D reconstruction, is immense. And that 200 or 300 rupees you save is not worth it, because if you have a problem, if you have a complication, it's really not worth it. Also remember, he said 20 minutes you spend pre-op studying your scan. Study it well. Because the value of that time that you spend is more than made up in the operation theater. Because you know your anatomy so well, your steps are much quicker, and you will ultimately end up saving operation time, anesthesia time, and doing a surgery that is far easier with less or fewer complications. Third was, again, emphasize the importance of that middle turbinate, and it's try and save it as far as possible, because really radiology, surgery, everything is sort of goes around that. There was one more point that he made, was that using the DICOM images, sometimes the films that you get, are not true coronal or are slightly tilted, and that you can adjust and correct very easily on your DICOM images. So you're converting your laptop into the virtual CT scan studio. And so you can adjust the windows, you can adjust the tilts, you can adjust the coronal, you can measure distances. You can do all this on a CT scan. So I just want to take a few questions, Satish.
Yes, please.
Is there any role of an MRI in common clinical conditions?
Yes, very important. See, when we talk about the inflammatory disease of the paranasal sinus, particularly sinusitis, practically there is no role of MRI, unless there is some impending complication, or unless you see something on CT scan, some disease going beyond the confines of paranasal sinuses, or patient has some unusual symptom which is not explained by CT scan. So those are the indications for an MRI. Routinely, MRI is not indicated for inflammatory disease of the paranasal sinuses. And Nishit, to your point, what you have taken about the DICOM images, practically, believe me, the area we scan for the sinusitis is almost 20 centimeter in all planes, 20 superior, inferior, anterior, posterior. Now, to acquire the entire data, 0.5 millimeter. 0.5 millimeter means 20 centimeter, 200 millimeters, 0.5 millimeter, 400 slices in one plane, 400 axial, 400 coronal, 400 sagittal. You can change your window settings, soft tissue, bone, everything on the DICOM. 1200 slices for a patient to carry as printouts is almost impossible for the radiologist to give, for the patient to carry, and the surgeon to read. Simplest is the DICOM you can carry in a DVD, and you have complete information. Number one. Number two, I must congratulate. I'm really thankful to the Neelam and Sanjay for their publication on this radiological. That is a mind-blowing presentation. Believe me, mind-blowing publication on what actually need to be seen on CT scan of the paranasal sinuses for a radiologist. What radiologist should know, what surgeon should know, and that is something I would suggest everyone to go through. And same thing she has done for the cochlear implant as well, and that is amazing.
Correct. So it's far easier to have it on DICOM, not just from a film point of view, but
More
also to study
information.
coronal, axial, sagittal all together at the same time. And you get the flow. It's more like a video as compared to static images. Neelam, you want to add anything to what Satish and has already said?
No, amazing talk. I mean, he just covered all aspects and exactly what you said, Nishit. The points that he stressed, especially about really reading your own scans. Not all of us are lucky to have radiologists there at our beck and call to answer. So it's very important that we learn to do this ourselves. And I think it was an amazing talk, Satish. Superb.
Thank you.
Are there any questions from the audience? Because as far as I can see,
Not that
my
I
chat,
can
I
see.
can't see.
Yeah, so there is one more.
One
just
last
came.
question is, there was that old rule between frontal sinus, anterior ethmoid, posterior ethmoid, that rule of 6, 12, 24. How reliable is that? Should we depend on that at all, or should we just look at the scans?
See now, that question is very important. Earlier, when we had limited CT scans, sections available. Now with the DICOM with 0.5 mm with complete dynamic information, these informations are no longer of any significant use. Now you can use more reliable landmarks. You see why these distances were used as landmarks to prevent complications. Now, I have already mentioned on DICOM, you can see where your ground lamella is, where your superior turbinate is, where your rostrum is, where you have onody or not. So everything, all these informations are available, whether your anterior ethmoidal artery is in, mesentery, how is the cellularity above the anterior ethmoidal artery between the skull base and the artery. You can have each and every information on DICOM. So these now the lens, the 6 millimeter, 12 millimeter, are of no longer of any significant use now.
So we keep going back to do your full scans and spend time with your scans.
Yes.
Okay,
yes.
I'm sure we'll get more questions as we go on. So I'm going to allow Dr. Neelam Vaid to start her talk. And then Satish, if we request you to please stay on, because I'm sure we'll have more questions to deal with once Neelam's talk is over.
Sure,
For all the audience members, please keep posting your questions so that we can take it at the end of Neelam's talk. Neelam, you were already introduced by Dr. Mohan Kamishwaran for everyone. So we have this very enterprising, brilliant, not just endoscopic nose, but also ear surgeon from Pune, giving her talk on steps of FES. Unmute Neelam.
Thank you so much for the introduction, Mohan. I'm sorry I missed it. I will ask you to repeat it for me so I can hear good things about myself. Thank you so much, Satish, for that really, really nice presentation. I joined in a little late, but amazing talk. Is my screen shared? Do you have my presentation? Not yet?
Not yet.
Not yet.
Suhas?
Is it there now?
Yeah, it's coming on.
Steps, yep.
Yes.
Okay.
So just let me know when it's on so I can start.
You're on. You're on.
Yeah. So, what the topic that I've been given for today is basically to be talking about surgical steps of basic functional endoscopic sinus surgery. Whether we are doing this surgery for chronic sinusitis, or whether we are going to do it for chronic polyposis, or whether we are going to be using this approach towards, let's say, tumor surgery or towards any sort of lesion in the nose, I think the basic surgical steps will remain the same. And when we start out this, I mean, what is the objective? When you're doing any surgery, you kind of set off with a particular aim in mind. And in this, when you're doing it, especially for chronic sinusitis or chronic polyposis, you are doing it to reestablish the physiological function of the sinuses. Always try and preserve normal mucosa. A big challenge when you're doing polyposis, but that should be something that we should all make a positive effort at. And if, however, you see irreversibly diseased mucosa, which we characteristically call like a cobblestone appearance, then you may think about removing that diseased mucosa and removing any obstruction which prevents the ventilation of the sinuses. Every surgery and its outcomes are totally dependent on how we address a patient preoperatively. And in our minds, there should always be a checklist. It has to be the right patient and the right preparation. And it's outside the scope of today's topic, but when we say patient selection, it means you are doing the surgery for that particular indication if medical treatment has failed. And when we say medical treatment, we say appropriate medical treatment, which, depending on the physiology or the pathology that we are addressing, would differ. The patient preparation also thereby would either be antibiotics, would either be nasal sprays, would either be oral steroids, depending on the pathophysiology of that particular disease. One cannot stress enough the role of imaging, and I think Satish's topic just covered it amazingly. The importance of imaging, and he said that to you, is for us to devise a surgical plan. Because when we go in as a surgeon, there has to be some sort of a roadmap that this is what I'm going to be addressing, or this is what my instrument is going to have to address. And I think what's very important is what one of my teachers said, that a true surgeon actually knows or anticipates the region that's coming much before that region actually comes. And that today, with the sort of imaging that we have, has made things much easier. A consent and counseling, very important, especially in today's day and era. What's most important is that sometimes we don't anticipate, but then during the surgery, we feel the need to maybe do an additional procedure like a septoplasty, or address a spur, or address a turbinate which is looking a little more enlarged than what we saw on the imaging. So I feel that when one takes a consent, it's very important that you kind of counsel the patient and put it down on paper that if needed, these procedures may be done. Because tomorrow you don't want to be caught in that scenario where you haven't taken a consent and you have done one of these additive procedures, and the patient may create trouble for you there. Very important to enlist to a patient appropriate expectations. It's important that when we counsel these patients, we tell them that this is not a surgery where we are going to do something and that's the end of it. This patient has to be prepared for a prolonged follow-up, for prolonged post-operative care. The outcomes of the surgery, definitely the way the surgery is done has an impact. But what's more important, I feel, is whether the patient really follows up on the post-op directions that you will give this patient, which could be nasal douching, which could be using nasal sprays, again, depending on the physiology, pathology. So very important that pre-operative, all this is counseled to the patient before we really get down to the surgery itself. In the operating theater, again, a checklist, and this is our peri-operative checklist. This is in addition to confirming the patient, the site, etc., etc. An antibiotic is always given to the patient at the time of induction. We always give these patients a bolus of steroids. Hypertensive anesthesia, and the less, the more that's said about it is not enough. You need an anesthetist who can really give you an appropriate field. This is one surgery where you're really operating sometimes with a 4 sometimes with a 3 endoscope, and bleeding can make something which is a very pleasant and a smooth surgery into quite a disaster. Always remember to remind your anesthetist to put in a throat pack. Sometimes in the hurry of taking in a patient, or if you have a junior who's intubating, this step can be missed, and again that can have disastrous consequences. As far as possible, the endotracheal tube should always be fixed on the left side of the patient, and the entire connection from the endotracheal tube to the Boyle's machine should go under the left shoulder of the patient. The advantage of this is that all your instrumentation thereby does not get entangled in the tube or the connections, and especially when you're using instruments like the punch, or if you're doing surgery in the frontal sinus area, this little step makes a big difference, because otherwise you will have the punch hitting the endotracheal tube or the connections, and that can again cause issues with your surgery. We always do the first nasal packing at this time. That means just after induction, before the surgical team washes. One of us, either me or the residents, will do an initial nasal packing. We use the orthopedic normal cotton patties and dip them in lignocaine with adrenaline or saline with adrenaline, as whether you're using general anesthesia or local anesthesia. Having said that, for the last, I would say, almost a decade, I don't remember doing this particular surgery under local anesthesia. All my cases are done under general anesthesia, and that's what I'm comfortable with. I have an excellent anesthetist team, so I've never felt the need to do this under local anesthesia. Theater arrangement, very important. Where's the camera? Where's the light source? All this should be at a comfort level, because you don't want, once you started the surgery, no, I can't see, or the assistant's head is coming into your view. All this should be done before you start. Always check your equipment. Uh, Time and time I've again seen the cautery is not working, the suction's not working, and make a checklist here. It'll just make things much smoother for you as you go along. And of course, make sure that the CT scan is up there in the OT. If you're someone who uses, a CD or a laptop, I still use films. They should be up there so that in case you run into a problem, you have that. The position of the head, we've had a lot of studies that's been done on this, and you've had a study, especially the one that I've put down here, where they've actually compared the Trendelenburg position with a 5-degree, a 10-degree, and a 20-degree position. And what they found was that the best position for the patient was actually a 20-degree reverse Trendelenburg position. What we use is a supine with a head up of about 30 degrees. However, if the surgery is going to be focusing a lot on the frontal sinus, we have a lot of pathology there, then I might need to put in an extension below the shoulders, because that brings the frontal sinus much better into my view, and it makes it much easier for us for accessibility of instrumentation. The same would apply to skull-based surgeries. Again, keep an extension ready in case you need access to that floor of the anterior cranial fossa. The table being as low as possible is something that I learned over the years, and I thank Nishit for this. But interestingly, there's been actually a lot of study done by this particular surgeon who's looked at ergonomics and endoscopic sinus surgery. And you realize that if you are going to make a profession and you're basic focus of interest is going to be rhinology and endoscopic sinus surgery. So this is really important, because if you're going to be operating 2 or 3 cases a day, each case being at least about 2.5 to 3 hours, depending on whether you are a surgeon who sits or whether you're a surgeon who stands, these factors become very important. Because when you reach the age that I have reached, believe me, a back pain, a knee pain can be quite disabling. So very important to look into ergonomics. If you keep the table as low as possible, the strain on your elbows is much, much lesser. The way you position, where are you keeping your debrider, where are you keeping the cautery pad? Because remember, this is one surgery where you're practically using 4 limbs. You're using the hands to hold instruments and scopes. Your one leg will be either controlling the debrider, the other leg may be controlling the cautery. So you have to be stable, so at no given time is there too much pressure on any one of these joints. I am a right-handed surgeon, so I always stand on the patient's right side with the monitor slightly, on the patient's head, but more towards the left side. Like I said, you could be a surgeon who stands or sits. I am a surgeon who stands, the assistant on the opposite side, and a scrub nurse on the head end. I have lately shifted to having the assistant right next to me now, especially as you're doing more complicated cases. It's just easier for the assistant because he or she can see the monitor, and at the same time, the accessibility of the instruments is exactly in the same plane that you would like the assistant to be bringing the instrument in. So even in routine sinus surgery, sometimes you need that third hand or the fourth hand, and if you can get comfortable with your assistant standing next to you and assisting, and I think Satish and his team are an excellent example of that. It really makes your surgery much easier, and also the patient's outcomes are much better. This grip on the scope, very important. This is a very basic talk, so I'm assuming there are some people here who are just starting out surgery. Use whichever grip is comfortable for you. This is the grip that I use, but again, now I'm realizing that if I have a slightly longer surgery, this finger now starts to pain, and I will change my grip to either one of these. Always support the cables. That's very important, because otherwise you don't realize it, but the weight of the cable and the camera cable ends up tilting your scope, and half your energy is going in keeping that straight. So a very important point, always support the cables to prevent a strain on your wrist and your fingers. Always have 2 functioning suctions. Like I said, check all your instrumentation, and the dictum that always remains will remain. It's always the instrument that goes in first, and then the scope. And this is especially important now, since most of us are using powered instrumentations like micro debriders. You must follow this dictum, because otherwise you can injure normal tissue, and once you do that, the amount of bleeding can be so much that it will just hamper your vision for the rest of the surgery. This is a new grip that's especially come in for people who are doing a lot of skull-based surgery. Again, outside the topic today, but I just thought I'd introduce you to this. And for people who are really looking at doing prolonged endoscopic nasal surgery, this is an extremely good grip, where you have the suction and the scope in one hand, similar to what we call using the chopsticks. The word decongest can't be said as often as possible, because this is the first step that you're going to do in surgery. You're going to make that place that you're going to operate viable enough for the tissue, viable enough for the instrument to enter in. And what we use is patties soaked in saline with adrenaline. We use 30 cc with about 4 to 5 ampules of adrenaline. Recently, I'm also using pure adrenaline in some cases. The important thing here is always squeeze that patty really well before you insert it in, so you don't have the adrenaline dripping into the oral cavity. And that definitely decreases the absorption. please be open with your anesthetist and inform him or her that you're doing or using concentrated adrenaline. Most of them now don't get perturbed by it, and they can then deal with the issues if they come on. Have never had an issue for the last so many years, but I think that's because the anesthetist team and us share an excellent rapport where they understand that the importance of this is really makes our job much easier and sometimes even reduces the surgical time. So we've had this study that was done, and there was this discussion whether it's really safe to use concentrated adrenaline, and they have said it's safe. There have been no catastrophic events or something which is in any way not allowed us to use the adrenaline. But the important thing here, and which I stressed, is that you should have an open communication with your anesthetist team so that you and the team are on the same page. With any surgery, you're going to start first. Sorry for that. We're going to start with passing an endoscope. And I think the first thing would be the reason why you do the diagnostic nasal endoscopy is basically to see accessibility, to see do you have enough room for your instrumentation to go in, and to reassess pathology. I think diagnostic nasal endoscopy had a very, very big role when we didn't have such good imaging in place. But now, with imaging in place, this is more for me to assess, do I need to do additive procedures? So we'll just go back and replay this again. Yeah. So this is the first scope. We are now in the left nostril. That's the septum. That's the lateral nasal wall. That's the inferior turbinate. Passing along the floor, we've now entered, or we are about to enter into the nasopharynx, where we are seeing some pathology which is prolapsing through the other corner. That's the eustachian tube opening, and that's your torus. We're now putting in the second pass, where I have now gently retracted the middle turbinate with a forceps. That's the ground lamella, and that's the bulla. So again here, just looking at the pathology, is there something that's restricting my access if I'm going to be planning surgery on this side? And of course, the third pass, which is when you go medial to the middle turbinate and the superior turbinate over here, and you're seeing some polypoidal changes here in the opening of the sphenoid sinus. So these are the three passes that you do. Make it a habit to do it. The reason why is because if you are someone who's starting out, it gives you a very good hand-eye coordination, and that will help you as you progress on the learning curve of being an endoscopic surgeon. So as we discussed the first pass, you'll see the inferior turbinate, you'll identify the corner, you look at the eustachian tube opening and the fossa of Rosenmuller, and examine the posterior pharyngeal wall. In your second pass, you will see the uncinate process, you will see the hiatus simulanaris, the bulla ethmoidalis. You will assess how big is the agar bulge over here, is it prolapsing into the axilla, and look at if there are presence of any accessory ostia. Some tips and tricks: when you have a limited space, what you saw me doing there was to gently push the middle turbinate with a periosteum elevator when I'm doing the second pass. This has to be done very gently because you don't want to use a lot of force and damage this vertical lamella of the middle turbinate, because we know that's attached to the skull base. So just very gently, the periosteum elevator will do it. If there is a very bad pathology here and you can't access the second pass from anteriorly, you can also go posteriorly and roll the endoscope from underneath the middle turbinate and examine the middle meatus. So this is something that you can do. And the third pass, like we discussed, you will see the superior turbinate, you will see the sphenoid ostium, and you will check its correlation with the roof of the corner. Before starting out the surgery, you have to realize that most of functional endoscopic sinus surgery is in the middle meatus. So if we are going to be operating in the middle meatus, the three structures that can come in my way and they are going to prevent my scope or my instrument from going in is going to be either the septum or the middle turbinate or the inferior turbinate. And you need to make space for yourself before you start the surgery. A lot of us see these polyps in the middle meatus and we'll go straight in, and then you realize, oops, you have a little deviation of the septum that's coming in your way, and then we start traumatizing that mucosa on the septum and it starts bleeding. And once that bleeding starts, there's going to be a constant trickle of that blood posteriorly onto your scope, and that is going to make your surgery a little more difficult. How do I decide which is the septum that I'm going to operate or which I'm going to address and which is the septum that I'm not going to? So I base that on whether I can see the axilla. So this is the right side, and you can see the septum was not letting me see the axilla. Once I've done a septoplasty, I'm now able to see the axilla, and for me, that is the dictum. So if I have any septal deviation to the point where I cannot visualize the axilla of the side that I'm operating, I will do a septoplasty. And I must say that my tolerance or my incidence of doing septoplasties is quite high. I also feel that it really makes a big difference to the patient post-operatively because, like we stressed before, a lot of the outcomes of the surgery are dependent on post-operative nasal douching, keeping the nose clean, and that, if you have a deviated septum, is not going to be something that's going to help you. The other thing that can come in your way for the middle meatus is going to be a concha bullosa. And again, if I have or the patient has a concha bullosa, that's going to limit my instrument from going in, I will resect the concha. And it can depend. I mean, in literature, if you look at it, there are lots of ways to do it. You can do it submucosally. You can do whatever you want. You want to do it with a debrider. You want to do it with cold steel. That's your personal choice, but I always prefer to use cold steel instruments for the concha bullosa. At the most, I'd use the debrider just to shave off this mucosa and give me a smoother outline here. The inferior turbinate, especially if you're looking at pathologies which are in the maxillary sinus, I think doing an out fracture of the middle of the inferior turbinate is something that one should always do. The reason being, the instruments invariably need to go from below. And if we have an inferior turbinate like this, which is preventing me from seeing the inferior border of the maxillary sinus, an out fracture of the of the inferior turbinate, and really pressing it down laterally. And you can see now I have a lot more space now here for my instruments to go in and address any pathology that may be there. So these are the three structures that I will do much before or address much before I really start the endoscopic sinus surgery. The spur removal, again, the same thing. If you have or you're looking at a surgery where you may need a suction to keep coming in here and you may need your assistant to be assisting you like a three-handed surgery, I think remove a spur because, again, the suction will keep coming in. It will traumatize the mucosa on this and you will have incessant bleeding going on. So I wouldn't remove all spurs. The dependence of whether I'm going to remove a spur would again depend on what is the type of surgery that I have planned for this patient and what is it, whether the spur is really going to come in my vision. So this is just something where we've just removed or elevated the mucoperichondrium and the periosteum on the spur. You use a knife, you can use a freers, just remove that part of it which is deviated, and at the end of it you will see that this entire area gets flattened out and you have much easier accessibility for your instruments to go in. So this is the three or four conditions where one would really bother to remove and make room for yourself much before you start. So this is the bony part of the spur that I'm removing. Note that the mucosa is not really elevated too much, and at the end of it the mucosa will just fall down. And obviously when you're doing the surgery you will be a little careful that you won't damage the mucosa a little more. So that is spur removal. And So you can almost say that I'm doing like a limited septoplasty with a spur removal. And if you notice, the reason why I've done it is because there was this pathology posteriorly. Now, if I had the spur intact here, it would have been very difficult for me to address this pathology. So, like I said again, not all spurs have to be removed. But yes, if you have a pathology behind that, you need instrumentation to go in from inferiorly, then that's something that you may need to do. After doing that, you're going to decongest again, and here the role of decongesting very, very carefully with you can use periosteum elevators. Notice how gently the decongestion is being done, because again, if this is done very, very forcefully, you will rub the mucosa here on the middle turbinate, you will rub the mucosa on the uncinate process, and then you will damage this whole mucosa, which will cause a lot of bleeding. So I use a lot of the freers for my second and third packing. That's a little less traumatic. Infiltration, I only do if I am going to be doing septal surgery or concha surgery. I have stopped using infiltration routinely. That's a personal thing. It's not something that I'll advocate if you are comfortable with infiltrating. It's just that with the sort of anesthetic fields that I get today, I haven't felt that the infiltration has really added any more to my ease of surgery or the outcomes post-operatively. So concha or septum, if I'm going to be addressing these pathologies, I will do an infiltration. Sinus endoscopic surgery, I think, is one of the surgeries where really, fortunately for us, anatomically, we have lamella in place. And if one thinks of this surgery as the fact that it's actually a lamellar surgery, that means you go step by step, addressing each lamella as it comes, and you had Satish's talk telling you about that, it becomes just easier. If you do this step by step, addressing first lamella, which is the uncinate, then you go to the next, which is the anterior ethmoid, then the next, which is the ground lamella and the posterior ethmoid, then the superior meatus, and finally the sphenoid. If we look at the surgery as a step-by-step surgery, there is a very less error that can happen, and things can go wrong. So this, in my opinion, is how I would be handling any patient on whom I'm doing endoscopic sinus surgery. The uncinate, followed by looking at the maxillary sinus, identifying where it is. I then identify the frontal sinus drainage pathway. Then I will handle the anterior ethmoids, then enter the posterior ethmoids, the sphenoid. After doing this at the sphenoid level, where I can identify the level of the skull base, I finish the skull clearance at the level of the skull base, and finally come back and clear the frontal. So this is the way I do endoscopic sinus surgery, and there is a reason for this. Missing any one of these steps is something where disaster can happen, and you don't want that to happen. So let's come to the first lamella that we're going to address, and that's the uncinectomy. One has to remember that the uncinate, even though we think it's a thin bone, it has 3 layers to it. And that's one thing you should remember. So it has a mucosa anteriorly, it has a bone, and then it has a mucosa which is posteriorly. And as we know, it's an extremely important bone for visualization of the frontal recess and of the maxillary sinus ostium, which is hidden behind this. All this has been covered by Satish, so I'm not going to be mentioning it all. When you are doing a removal of the uncinate, dictum for beginners, retrograde is always safer. That means you come from behind. It's always safer. Vis-a-vis antegrade, because antegrade, you're very close to the orbit. Also, remember that if you have a very narrow fundibulum, or you have a maxillary sinus which is hypopneumatized, that orbit is really close to the uncinate process. Things that you're going to know by looking at the images beforehand. And anteriorly, there is a hard bone where the nasolacrimal duct is. Your dictums or your tip and tricks when you're doing uncinectomy, remember that the anterior limit is hard bone. As far as possible, when you're doing uncinectomy, never turn any sharp instrument laterally because of the proximity to the orbit. And it's a big bone and has 3 layers. Remember that. It is not as small as it looks. I'm now going to show you some ways in which you can remove the uncinate, and this first one is a backbiter. What we are first doing is defining the uncinate, and this is what I meant by look how big this bone is. It's actually right from here to posteriorly here. The first thing that you do is insert a backbiter, and here I'm going to just pause it. The backbiter that I use here is not the standard Antrim backbiting forceps, but I use something called a toy B because its blade is a little smaller. And what I've realized is that when you use this, the chances of your damaging a posterior structure, which is the bulla, are much lesser. So I prefer to use a toy B. And the first cut that is done is taken at the junction of the vertical and the horizontal part. So you do that and you take about 2.5 cuts till you hit that hard bone. And once you do that, what you should start seeing over here should be the natural ostium, unless you have a pathology there and you're not able to see, which in this case is a lot of polyps. The remaining part of the uncinate you can remove either with a debrider, as you're seeing me do in this patient, or there are other ways that you can also use it. Complete removal of the uncinectomy is one of the most important steps, because if you look at the causes for revision surgery post FES surgery, one of the commonest reasons is an incomplete removal of the uncinate. This is again another way to do the uncinate. And here you can see that the pathology is already made, a break in the uncinate. And look at this uncinate. It's extending from here right up to there. And again, a backbiter. I'm now showing you the left side just to give you an impression of how we do it on the right and the left. And here now you can see there's less pathology. So you can see the natural ostium of the maxilla over here. So this is how you would do it with a backbiter. This is something that you can use a freer elevator. I would advise this to be done in those patients who have what we call medially everted uncinate, where you have the uncinate kind of turned on itself and facing anteriorly. Extremely good, because in this you actually manage to remove both the vertical and the horizontal part in one go. Again, remember, a freer to be used, not a sharp instrument like a sickle, because you can inadvertently enter the orbit. But I would advise this only in those pathologies where you can distinctly see the anterior attachment of the uncinate. Of course, someone like Nishit, he always prefers to use the freers, and it's something that I actually learned from him. But that again is something that depends on your level of comfort, and then of course clearing the entire thing with a micro debrider. The other instrument which again you can use to do is a punch, and here you've taken the cut with the with the backbiter or the toy bees. And what I'll do now is use a punch at the attachment of the anterior border of the uncinate over here, and it can give you a beautiful clean uncinectomy right up to here. So if for those of us who maybe don't have a debrider, or for some reason, the debrider is blocked, it's not working, and your assistant is trying to get it to work, this is another instrument that you can use in the meantime, and it gives you a very, very clean uncinectomy. So these are the various methods in which you can do an uncinectomy. After you finish an uncinectomy, the next step that you're going to do is now identify landmarks. And the first landmark that you want to identify is the natural ostium of the maxilla. Again, Satish has spoken about this. The tips about medial maxillary antrostomy is you always, if the patient has an accessory ostium, will connect the normal ostium to the accessory ostium. You will avoid creating a circumferential raw area. And this is especially important superiorly, because a lot of the mucociliary drainage of the maxillary sinus actually comes from the superior border. So avoid as much as possible creating raw areas, of course, circumferentially and especially superiorly. Avoid damage to the nasolacrimal duct anteriorly and the posterior nasal artery posteriorly. There can be some conditions where you either have an extremely lateralized or a hypopneumatized maxillary sinus, where you're not able to see this sort of anatomy. And the trick there is to then just take a curved suction or a ball probe on the superior border of the inferior turbinate and gently dip it down laterally. It will usually find the maxillary ostium for you. Always look for air bubbles when you are probing this area. It gives you a hint of where the opening of the sinus may be. And stop if the bone is hard, because you're obviously in a wrong place. This has been covered by Satish. So this is just showing you how we would do this. We've now removed the uncinate. We are removing the inferior part. As you can see, the maxillary sinus is identified. I can see the opening here. And with the debrider, I'm gently just removing that part of the mucosa that's prolapsing and covering the ostium. I'm not interested in making a very big opening, just making sure that on all sides there is mucosa which is lining it. This is very, very important. And I think the microdebrider has been a boon for us for this, because it can just gently shave off that part of it. So this is the same one. Another one where I'm now doing it on the left side. I'm just trying to show you both sides differently if possible. Encinectomy being done with the microdebrider. You can now see the maxillary sinus opening here. There's edematous mucosa, and I've just removed enough and made sure that I've not debrided this. There's always this discussion about how big do you make this opening, and that really depends on what is the pathology that you're doing. If you open up and you see a normal maxillary sinus, there's absolutely no reason for you to make big, huge ostium openings. But if you have a lot of pathology in the maxillary sinus and you need 2 or 3 instruments to go in, like a suction, a debrider, a curved blade, then obviously the opening has to be much, much bigger, because the blade of the microdebrider or the instruments that are going to enter the maxillary sinus are going to have a curve. And you're going to have to remove this posterior wall enough for that instrument to have access inside. Sorry. Okay. Another maxillary sinus opening being done. This is only with cold steel instruments. This is again the left nostril. You have the middle turbinate, the lateral wall of the nose, the septum. Just removal of the inferior part of the uncinate. You can see that the ostium has been identified, and just with the ball probe, we are just making this opening bigger. So this tissue will then subsequently be removed either with a debrider or with a scissor or with a forceps, whatever is the instrumentation that you have in your armamentarium. So just different ways on how to do this. After I finish doing the maxilla work, I always identify the frontal recess at this particular time itself. And that gives me a comfort level. There are 2 ways that you can, at this point, identify the frontal recess. You can use what's called the intact bulla technique, or you can use what's called the axillary flap technique. Basically, what it means is that the intact bulla technique works on the anatomical principle that the opening of the maxillary ostium and the frontal sinus opening are in the same perpendicular plane. Thereby, also the injury, if possible, or if it may occur to the anterior ethmoidal artery, is reduced, because your instrumentation does not go beyond that anterior edge of the bulla, and anterior ethmoidal artery is going to be way more posterior to that. So that's the principle on which the intact bulla technique works. The axillary flap works on a different mode. What that works on is an anterior approach to the frontal sinus. So what that works on is that you remove all these structures of your frontal sinus drainage pathway, which Satish must have said, like the anterior wall of the agar nasi, and you remove it in such a way that you address the drainage pathway from anteriorly. So you can either do it with the intact bulla or the axillary flap technique. And again, the pathology will decide that, because if you have a patient who has a very big agar nasi, then the axillary flap is easier. However, if you have a patient with a very small agar nasi, then obviously the intact bulla technique may work better for you. So you will decide that based on the imaging. And this is just the same thing that I'm showing you now with a diagram. This is your left nostril, the middle turbinate, the lateral nasal wall. the bulla, that's your maxillary ostium. And if you put in an instrument just along the border of the anterior of the ethmoid bulla, you should enter the frontal sinus drainage pathway. All depends on the cells that you have here. And when you're doing an axillary flap or an anterior approach, you remove the anterior wall of the axilla and you are there in the frontal sinus drainage pathway. So these will be the two approaches. And at this point, you're just identifying that this is the area where the frontal sinus is draining. You're not doing any extensive surgery here at this point. For identifying the superior or the frontal sinus drainage pathway, it's very, very important to remove the superior most part of the uncinate. We are in the right nostril, that's the middle turbinate, that's the lateral nasal wall, that's the axilla. And what we are doing now is removing this entire superior part of the uncinate, because only after removing that will I be able to see the axilla now. And what we've opened now here is this huge agar nasi cell. And depending on what the imaging is going to show me, I am going to go either posterior to that or through that. But very important that if you are going to be using the axillary or the anterior approach to identify the frontal sinus drainage pathway, that you remember to remove the superior part of the uncinate process. The other points that you can use is sometimes there is just a small little pathology there which kind of gives you an idea that's where the frontal is draining. And in this patient, we just have this small little polyp. The minute you remove that polyp and you put in a scope, you knew you were in the frontal sinus. So sometimes small pathologies like that, a little bit of secretion, etc., can also guide you to where the drainage may be. This is something where I'm showing you how the intact bulla technique works. This is the middle turbinate, this is the lateral nasal wall, and that's the bulla. What I'm using here is what's called the Kuhn forceps. And what you can see is I'm placing the Kuhn forceps along the bulla and just gently going up. Maxillary ostium down there, and that's the frontal. So same perpendicular plane. Gradually, I'm finding it. I then put a curette and make that opening a little bigger. So the safety of an intact bulla technique is definitely that if you're not going far back posteriorly, the chances of damaging the anterior ethmoidal artery are much, much lesser. And this is something that I would urge all beginners at least to start off with. It just makes your life a little more easier. And excuse me for the quality of this video, it's one of my old videos. This is showing you the anterior approach. You have again the uncinate here. There is a lot of disease. This is the middle turbinate. You're in the right nostril. With the microdebrider, I'm doing an encinectomy. I'm removing the anterior wall of the axilla over here. And what you'll see open up here is the agar nasi cell, anterior wall of the agar nasi. I don't know why I'm calling it the axilla all this time. And once I remove this, I have now a direct visibility into the frontal sinus drainage pathway. And you can do this surgery then with a 0-degree forceps, and you don't really need to use angled instruments. You can use a punch to remove this anterior wall of the agar nasi better. And as you can see, as I remove it, I'm getting better and better visibility. For this sort of approach, be very, very careful that you preserve the mucosa here, because if you do a damage of the mucosa on both sides, that means the middle turbinate and the lateral nasal wall, chances of adhesions forming are very high. So this has to be with sharp cutting instruments, punches, debrider, or a true cut. But those are the instruments that I would suggest here, not recklessly forceps.
Neelam, sorry to interrupt. Sorry to interrupt. But you think we can finish in about 10 minutes?
I can go really fast. Okay.
Don't go super fast, but try 10 minutes.
Okay. So, okay. So what I'll do, Nishit, then I'll just show the videos. Is that okay?
Yeah, sure. Sounds good.
Okay. So for anterior ethmoidectomy, you have two approaches. You can either enter the bulla from anteriorly
That means you puncture the anterior face of the bulla. You can use a Freers, you can use a suction, any instrument that you want, and then remove all these cells. The other approach that you can do is using what's called the drainage pathway of the bulla, which is from the retrobulbar area, and that's this. So this is the bulla, middle turbinate, lateral nasal wall. You put in a curate into the bulbar space and break the bulla anteriorly, and then remove the entire anterior ethmoidal cells. So this is two ways that you can address the anterior ethmoids. Once you have done that, in this particular area, the structures that you have to be careful about are laterally the orbit, superiorly the anterior ethmoidal artery, and the skull base. If you follow the techniques that I have just seen, then right now, damage to both these structures is not possible because the skull base is much, much higher. Remember, the instrument should always be parallel to the lamina papyracea. Always use the side of the forceps and always, always point it away from the cribriform plate. If you're using a microdebrider blade, it should never face laterally. One of the common questions that we have is how do you identify the ground lamella? We've now removed the entire anterior ethmoids. Look at the middle turbinate. So this is the vertical attachment of the middle turbinate. That's the horizontal attachment. If you come up from there and just where it bends forward is the ground lamella, always puncture the ground lamella as inferior and medial as possible, and then remove the entire ground lamella to expose now the posterior ethmoid cells. As far as the posterior ethmoid cells is concerned, you know you're in the posterior ethmoid cell when you have identified the superior turbinate medially. So your landmarks would be the superior turbinate medially, laterally would be the lamina, and of course posteriorly till the orbital apex. So, this is going to be your landmarks when you finish a complete posterior ethmoidectomy. Just quickly showing you a video. Again, this is the left nostril. What you're now doing is where you entered the ground lamella. You have some pathology there, which you're cleaning up with the debrider. And what you're trying to do now is identifying where's the superior turbinate, and this is the lamina. So the minute you've identified your superior turbinate, you know now that that's your medial border of the posterior turbinate. With the instruments, you got a level of the skull base, so you can remove all these cells because the skull base is much higher. So posterior ethmoidal surgery, that's your skull base now, superior turbinate here, lamina here. Once you've done this, you've now completed a complete posterior ethmoidectomy. Again, a similar one, I'll just go fast. For posterior ethmoids, always remember that the base of the skull slopes more inferiorly, so be careful there. The lamina papyracea will curve more medially. Your imaging will give you an idea of where the optic is. Do you really have an anode cell? And remember, in normal situations, the posterior most cell will always lie posterior to the anterior wall of the sphenoid. So be careful. Don't think that the sphenoid will be more posterior to this. If in confusion, am I in the posterior ethmoid cell or am I in the sphenoid, always follow what's called the maxilloethmoid line, which is a line from the superior border of the maxillary ostium. Project it posteriorly. If the cell is below that line, it's the sphenoid. If it's on top of it, you are in the posterior ethmoid. For the sphenoid sinus, you have three approaches: lateral, medial, and intermediate. The lateral is when you approach it from the cavity of the posterior ethmoid. Look for color change. If you look at the color change, this is white bone, this is a bluish bone. And if you see a color change that you're most probably entering, that's the sinus. It's always more inferomedially, and when you finish the surgery, you always connect it to the natural ostium. Another one here, you can again see the color change here. Look at my instrument. This is the right nostril. It's going inferomedially, and I'm going to connect this to the natural ostium. That's the superior turbinate over here. That's the lamina. That's the skull base. That's the opening into the sphenoid, and now you're seeing this disease in the sphenoid. And you can enlarge it with a punch or with a debrider. Today's debriders can even remove bone, so you can even use that. That's just showing you the anatomy in the sphenoid. The medial approach is the one where you go between the middle turbinate and the septum. I don't advocate this anymore. If I have to use a medial approach, it will be between the superior turbinate and the septum. You don't want to destabilize the middle turbinate. And if you end up doing this, then you have to do and fix the middle turbinate. Identify the sphenoid ostium. We know that it lies about 1.5 centimeters above the roof of the corner. The intermediate approach is one where you have the opening made laterally, you have the opening medially, and you'll try and connect these two. So just quickly showing you, this is your left nostril, superior turbinate, lateral wall. That's the natural ostium. And what we are doing is with a true cut, we are removing the inferior 1/3 of the superior turbinate, and we will then connect this natural ostium, remove all this bone here, and you will have a big opening of the sphenoid sinus. Here I'm using a punch to do this. Once you're in the sphenoid sinus, this is outside the domains of this lecture, but you will identify the various structures. After identifying the sphenoid sinus, you now have an idea of what the level of the skull base is. You will use this instrument. It's an amazing one. It's a curate with a small turn over here. Move the instrument posterior to anteriorly at that level of the skull base, gradually coming forward and breaking the cells. This is more of tactile surgery, less of vision. You've got to go by feel. Is this bone breakable? Is it not breakable? Is it hard? And if at any stage you do not push this instrument superiorly, very, very gently, and if you do it that way, you're able to identify the anterior ethmoidal artery. You already have an idea whether it's close to the skull base or is it hanging, and thereby the level of safety will be much more. This is after completing the whole skull base surgery. We have now identified where the anterior ethmoidal artery is. So you'll see it obliquely in a coronal plane, and you'll always find that it runs posterior to anteriorly. Frontal sinus, this is again a very topic by itself. The anatomy will give you an idea how you're going to do about it. I always come to the sinus right at the end because surgery in the frontal sinus involves a lot of curved instrumentation. It involves using angle scopes. If you're using angle scopes, you need instruments that are curved much more superiorly, which means you need a lot more space posteriorly. So after you've done an anterior, a posterior ethmoidectomy, then when you come back and do surgery of the frontal sinus, it's much easier because your instruments have more place there. I'm not going to play this video, but this is just a surgery which we had a Kun 3, and the surgical kit actually shows you how we have addressed each cell and finally found the opening. So at every stage we thought, oh, this is the frontal, and then we saw one more cell on top of that and one more cell, and finally we found a Kun 3 and we were able to open it out. Because of time, I'm not going to show that. General tips during surgery, always make it a point every time your scope comes out of the nose, your assistant cleans it with saline, especially the tip. Dry blood on the scope will reduce light and the life of the scope. Keep patties and wait. If there is bleeding, take your time. And irrigation makes a world of difference. So if you are running into a problem where there's a lot of bleeding, just have your assistant constantly irrigating with warm saline. And believe me, the whole bleeding clears up. And here you'll see my assistant constantly giving me pulses of warm saline, which is helping me see much better. This is just some references for that. It doesn't end with just doing all this. After surgery, a cool down period, wash the nose properly, remove all bony pieces, check the middle turbinate. Is it become unstable? If it has, do a vulgarization with packing if you prefer. I now use the turbinate stitch, again, thanks to what Nishit has taught. Check for any postnasal bleeding, and always, always check your patty count. Take that extra care of your equipment at the end. Run the micro debrider through saline. This is thanks to Nishit. This is just a video showing the stitch. And now since Nishit is asking me to hurry up, his video is not going to get shown. This was just a reference which shows that if you do this temporary suture and medialization of the middle turbinate, it makes a big difference. The learning curve of endoscopic sinus surgery, like most other surgeries, is not as smooth as we think it is. It's going to have a lot of ups and downs. Just when you think you're becoming a great endoscopic surgeon, there will be some little pitfall that will teach you that you made a mistake. So it's a learning curve that keeps going on and on. For me, the learning curve has benefited a lot by these scope workshops that we've done over the years. It's been immense learning from both the faculty and the students at every workshop. I would like to acknowledge these four people who've been very instrumental in my journey. Nishit's been an extremely great mentor, guide, still is. I still ring him up for all sorts of problems. Uh, Siddharth and Mihir have been my co-learners. We've gone on this journey together, and it's been something where we still support each other. And I can't do endoscopic sinus surgery without Ajay, who's like my right and my left hand. So thank you very much, ladies and gentlemen, for the opportunity to make this presentation. I've never given a presentation so fast.
Thank you, Neelam. Sorry to rush you there at the end, but we were a little over time.
Yeah.
Spectacular talk, and your videos are just amazing, amazing, and very systematic talk. Covered all the possible aspects from consent to sphenoid. So just wonderful talk. Can we get Dr. Satish Jain also on the screen? If Satish,
yes, Nishit.
So we got a lot of questions now, and let's just ignore the titles of your talk. So feel free, both of you, to answer all the questions, because there's going to be a between radio and FES. So our first question is, what is the concentration of adrenaline when you pack the nose, and is there any difference in a hypertensive patient?
See, Nishit, Neelam has already mentioned this particular aspect, that she mentioned very clearly now that she doesn't mind even using a pure adrenaline in certain patients. The reason is so obvious. Adrenaline we use to maximize or improvise the surgical field, but mostly topical, not injectable. We no longer inject anywhere in the mucosa any sort of infiltration for that matter. So topical you can use in any patient with utmost safety without the risk of any systemic consequences, and mostly in younger patient we almost always use a pure adrenaline, except in very elderly and very dicey patient, cardiac patients. We generally dilute by 1:4 or something. Otherwise, we use pure adrenaline for topical use in all nasal surgeries.
So just want to add a little rider to what Dr. Satish Jain said. You note that both of them are not injecting so much adrenaline, so you're not preloading a patient with adrenaline. And also, both of these are phenomenal surgeons who do their surgery with minimal mucosal trauma. Please understand this, that your pure adrenaline is very effective. But if you have a situation where you have a generalized mucosal trauma, and then you're trying to stop bleeding in all areas with pure adrenaline, that then becomes a little area of concern. So use it in localized areas, and preferably try and avoid too much mucosal trauma. Okay, next question is for you, for anyone. When is the best time to do a CT scan, pre-op, and if necessary, post-op? This is from Dr. Renbonthung Lotha from Dimapur.
Okay, see, that's a very good question. First of all, the indication and timing for CT scan. Timing is very important. As I mentioned in my talk, the sinusitis is mostly diagnosed on clinical grounds. Patient symptomatology, if you look at the definition of CRS by American Society, if you have two major symptoms along with some minor symptoms, is persisting for more than 3 or 12 weeks is CRS. So mostly it is diagnosed on clinical grounds along with nasal endoscopy. Now the situation is, most of the time the situation is straightforward surgery. Like if patient has massive polyposis, grade 3 polyposis coming down in the nasal cavity blocking the airway, that patient, yes, medical treatment can improve to some extent, you can buy time, but ultimately will require surgery for access to the topical steroids. So in those patients you can get a CT scan done early and post for surgery. Otherwise, those patients with not having massive disease on endoscopy, yes, symptomatology pointing to CRS, you can start medical treatment on the basis of clinical diagnosis. If doesn't improve and you plan for surgery, then is the best time to get a CT scan done for those patients. So CT is mostly required for gauging the extent of surgery and planning surgery, not for diagnosis. So that's how we plan our CT scan timings according to the clinical and endoscopic situation.
So since you mentioned polyposis, would you then prefer to give the do the CT scan after the medical course of steroid so that you have more anatomy visible as against pathology?
Yes, so that's a gray area, I would say. I mentioned because these patients will ultimately require surgery. So a patient with massive polyposis is unlikely to be cured by medical treatment alone. In those situations, you can plan surgery according to the patient counseling and all that, and you can get a CT scan done early rather than waiting for the medical treatment to come into effect and waiting for the medical treatment failure to cause an indication for surgery. So this is basically a gray area where you can ultimately plan surgery and you can do it early as well.
So Neelam, how early would you say is allowed, and when would you say no, I want to do a fresh scan?
Uh, are you saying preoperatively, right?
Pre-operative. So is it
Yeah.
like 2 months
So
okay, 3 months okay?
preoperatively,
When would you say that no, now I need a new scan?
no, the new scan, I won't really ask for Nishit because the new scan, like Satish said, we need a scan for anatomy. Pathology we are seeing, we are visually seeing it. Unless I'm expecting or finding that there may be some other pathology that I'm expecting, like let's say unilateral polyposis, am I thinking of whether the patient also has an inverted papilloma? Then I might ask for a second imaging. But if I'm just using imaging for anatomy, then I'm okay with a scan, even if it's done about 3 months back, for the simple reason that a scan is just giving me anatomy. Personally, I would, even in a case of polyposis, do give the patient some amount of, pre-scan medication. I would give the patient a course of steroids. I will tell them that you will feel better with the steroids. But the reason I'm asking you for the scan is because once the disease reduces, I will be able to understand the anatomy a little better. Also, if I'm going to operate this patient, if I have optimized his nose in the sense with antibiotics and with steroids, my surgery will be a little more easier. So I think like the pathology will decide when we are doing it, but most of my patients will go for a CT scan with some amount of preparation.
So Satish, say you don't have a polyposis patient, you have a CRS patient who's had a sex scan 4 or 5 months ago. Will you then want to repeat a scan to see if there's any change in pathology?
Not
No,
unless there's something in the symptoms that makes me think otherwise. So if he's suddenly saying he's got blood-stained discharge, or I'm seeing pathology in the left side, but he's saying he has more obstruction on the right side, which wasn't there before, let's say 6 months back, only then. But CRS, pure CRS, clinical suspicion, no, I wouldn't.
Satish, same?
yeah, I agree totally with Neelam that we are basically getting this for anatomical information. And even if the medical treatment fails for say 3 months, whatever, 5 months, as you said, and you plan for the surgery, the anatomy is not going to change. So we'll
Okay.
be okay with the same scan what we had done earlier.
Okay. So Dr.
Unless,
Rajesh,
unless, unless like me, Neelam mentioned, unless some funny things come, some unusual symptom points out, or something which is not explained by the previous CT scan, any
so if you
kind
have
of
a change
suspicion, any
in
kind of
symptoms,
complication, yes, any
or if
kind
the
of
site of symptoms
complications
change,
or anything, yes.
So, Dr. Ravi Kishore from Bellary is asking, how do you identify the ground lamella in a patient with extensive polyposis, intraop?
I think I already did mention that, but a lot of decongestion definitely will help you, because even the biggest of polyps, if you decongest and you remove them or you do a debulking with a microdebrider, you're able to get quite a bit of the bone visualized. At the end of the day, if you're really lost, follow the middle turbinate. As I said, it has a vertical attachment and it has a horizontal attachment. Go posteriorly, see the horizontal attachment of the middle turbinate, and then bring the instrument gradually forward. At that part where the instrument dips superiorly is where your ground lamella level will be. Because if you look at the anatomy, and Satish explained it very well about the three attachments of the middle turbinate, the ground lamella is in that second part, and that's the place where it will just dip up. So that's one of the strongest landmarks that I use if I'm really lost. Horizontal part of the middle turbinate, start tracing it anteriorly, and you'll gradually feel that bone dipping superiorly. That's where you're going to find the ground lamella.
Satish?
Yes. So exactly what Neelam said, we follow that. And one more thing to add, like Nishit, you have already mentioned about the utility of middle turbinate for keeping you oriented. So here, if you are keeping the first part of the middle turbinate intact in your view, you can follow that behind, continuing as a ground lamella. Number one. Secondly, we follow the intact bulla technique. So when you keep the bulla intact, you debride the polyps, and if your bulla is intact, you gently pass on your probe behind the bulla. That retrobullar recess is a very important guide to preserve the ground lamella from debridement. So both ways you can easily identify the ground lamella even in the difficult situations.
Yes, good point. The next question is from Dr. Ram in Tirunelveli. What is the role of a coablator in polyp or fess surgery?
Not much for a regular fess surgery. It's not essential, I would say. Debrider is a basic tool which is required. It should be part of armamentarium. Cobblator, in case you are doing some extended phase, in case you are doing some draft, in case you are dealing with a lot of mucosa and coming across with the bleeding, yes, cobblator can be a fancy item to deal with that with some additional cost. But by and large, in the regular sinus surgery, it's not needed.
I think the only place where I may really mention a coablator, Satish, and I think maybe you'll agree with me, is, let's say the patient does have an issue whereby there is a tendency to bleed a little more. He has some intrinsic vascular issue. In that case, maybe, with the microdebrider, what happens is we all do realize it does create a little bit of trauma on the edges, and we do have an oozing. A coablation may help there, but I mean, that's theoretical. Have I really practically ever used a coablation for FES? No, but I've used it for, as Satish said, extended FES surgeries or
For
ESS.
tumor surgeries and where you need to take
Yeah,
mucosa.
so extended, not FES per se.
Dr. Firoz from New Delhi is asking this. How do you address huge polyps coming out of the nasal cavity to have space inside the nasal cavity to access the sphenoid, ethmoid, or the frontal sinus? So very extensive polyps.
I think it's the
See,
same thing. Sorry, Satish, go ahead.
yeah,
Is
carry on. Continue,
Nahi,
Neelam.
bolo, bolo. Bolo, bolo.
See, this is more of a problem in tumor surgeries, not in polyps. But polyp you can shrink with your adrenaline to a great extent, and still you can get a preserved anatomy. Even if you start the polyp debriding from the anterior nares, still you can get a very good preserved anatomy with a turbinate on one side and the septum on one side, and keep debriding, keeping your debrider blade in view. Keep debriding, preserving everything. This is more of a problem in tumor surgery when the tumor is coming out of the anterior nares and you have hardly any space to negotiate your instruments, and even if you try to, it can start bleeding, which is not a big issue in polyps. So polyps you can manage keeping your micro debrider blade in view, and you can keep debriding, keeping everything important structure preserved.
I think
Neelam?
the dictum that I said right in the beginning, decongestion, it's amazing. You've got to be patient. Sometimes you may have to do 4 or 5 rounds of decongestion, but as Satish said, a polyp will decongest. So if you put in adrenaline and you just wait it out, you'd be surprised that something which is coming right outside the nose when you started the surgery, by the time you actually put in the scope, has shrunk to such a point that you can just see polyps in the middle meatus. So take
Absolutely.
that little extra time before you are in a hurry to go inside and attack the pathology.
Correct. So I think it's important to decongest a lot, and also if you have to debride, start from a safe area. So start from inferior, try and stay in the middle of the cavity, not too close to orbit, not too close to middle turbinate, till you can see. Maybe if you see a little bit of the turbinate, then you can ride along the turbinate with your debrider facing laterally. If you see a little bit of the orbit, ride along the orbit with the debrider facing medially, and that way you can generally luminize and find a middle meatus. Dr. Abhishek Dayal from Patna, please elaborate on surgical importance of the supreme turbinate and the Parsons ridge.
Satish.
Supreme turbinate, is not a common anatomy, first of all. And see, whatever, even the superior turbinate, the issue is it is more medial, attached to the skull base, and as general precaution, you are not supposed to pluck it, pull it, or whatever, because all these turbinates are attached to the skull base. Supreme is a sort of, uncommon anatomy, which is very high up medially, uncommonly found, and the same precaution you need to take is like middle turbinate, not to, handle with care. That's the only thing which is required.
Is there a possibility of a higher incidence of an ONOD cell if you have a supreme turbinate?
Not really. Yeah,
I have no idea.
practically Nishit.
No, I've
Practically
never
Nishit. All
read
of this.
that. No, never read
Ever
that.
since, ever since we have adopted the approach of medial, passage after entering into the posterior ethmoid, we take a medial route to look for the sphenoid ostium and then sphenoid entry. Ever since we have taken this approach, we have stopped looking at the ONOD at all. Believe me, you don't need to bother about ONOD, whether there is ONOD or not. It is very, very safe. And even if it is ONOD, it will make it obvious. And you can have a very, very safe, medial entry to the sphenoid without damaging anything. So supreme turbinate, I don't think has anything to do with the incidence of ONOD.
And you know from your scans, of course.
Yes, very clear.
Dr. Elizabeth from Ernakulam, can you mention the blades you use with a debrider in each step?
So for just debulking, initially it will be a 0 degree. When I'm addressing the uncinate and the medial maxillary antrostomy, I'll use a 12 degree because the advantage of that is it also kind of medializes the middle turbinate a little bit, and I get visibility as to what the blade is doing laterally. Surgery inside the maxillary sinus would depend on where the pathology is. Usually, it'll be a 60-degree blade. However, if I have disease or pathology in the anterior wall, I might need to use a 120 degree debrider. For the frontal, it's going to depend on which is the scope I'm using. Remember, the dictum is that the debrider blade should always be more than the angle of the scope of the visible endoscopes. If I'm using a 70-degree, then all my blades will have to be either 90 or 120-degree for the frontal. If I'm using a 45-degree scope to look into the frontal, then I can use a 60-degree debrider blade. So for the frontal, it's going to depend a lot on which is the angle scope that I'm using for the instrumentation. But this would be by and large the dictum. For the sphenoid, of course, it will be a 0 degree. I think I tried to
Your
summarize.
thoughts?
So yes, same like Neelam, just to add on to it, to work in the far depth of the maxillary or the frontal, we use 120-degree. It makes your life more easier, and it makes it more, visible. With your 70-degree scope, you can work in the far depth of frontal sinus or maxillary. Another one is a reverse blade or the adenoid blade we use with a 70-degree at the skull base, because the reverse blade or the rear facing blade becomes a front facing blade once you use with a 70-degree, and it becomes very very safe to work at the skull base, coming from the frontal to the anterior ethmoidal skull base. So these are the two additions I would make to what Neelam has said.
So you can use like a 360 blade.
Yes, yes.
Okay, very good. Our next question from Dr. Gauthaman from Chennai. Are 14 centimeter length endoscopes sufficient for FES, or do we need a 18 centimeter scope?
I think 18 centimeter scopes are only when you're doing beyond the sphenoid surgery. For endoscopic FES, the topic of today was, I think 14 centimeters is enough. If you're going beyond the sphenoid, then you may need longer scopes. And I think Nishit, maybe you can be a better.
See, for sinus surgery, we should use only 14 centimeter. Reason being, what sinus surgery we are doing is a monoocular surgery. It's not microscopic binocular surgery. And with your movement of the instrument and the endoscope, 14 centimeter endoscope with close-up view, and the movement of the instrument in the other end makes you a three-dimensional perception. Longer the scope you use, lessens your 3D perception. Your perception is definitely changed when you use a longer scope. So for sinus surgery, we must use 14 centimeter only. For deep skull base work, of course, you need a longer scope for the better visualization. But the perception changes when you use a longer scope for sinus surgery, as it doesn't give that kind of a perception in your mind for those structures in the sinuses.
So that's a good point, Satish. The next question is from Dr. Kamal Pandyan from Shimoga, Karnataka. Any tips while handling an angle scope? As a beginner finds it difficult to handle instruments and angle scopes at the same time. And we see often that with an angle scope that the whole image tends to rotate, or you lose your orientation, or instrument is hitting against tissues. So what are your tips of how to use an angle scope and instrument at the same time?
See, Neelam has already pointed out in the beginning. With 0-degree, you look what exactly your endoscope points, and your eyes is looking at the same point. But that optical illusion happens when you use 70-degree or whatever scope. Now, what Neelam has pointed out, that's a simple method. Push your instrument first inside and follow it with your endoscope. It's not like that you use your endoscope first deep inside the nasal cavity, 70-degree, and then bringing your instrument further inside. Then you'll lose orientation. So first, at the anterior nares, first put your instrument in front and then follow with the endoscope. It's a navigation sort of a thing with both hands, where the instrument is going in and out with the visualization of the camera with the telescope. So the instrument should be first, and you can easily get used to this thing. So that's the bottom line what she has mentioned. First instrument, then scope. That's it.
And this is a habit I think you have to have even with a 0-degree scope.
Yeah.
Because only that's your best way of avoiding mucosal trauma.
And I think it's a learning curve, yeah. At the end of the day, this is something you'll keep trying, and you'll learn it. It's something that I think it comes with experience. None of us, when we started, we had any book or something that taught us this. It's like we kind of walked it out ourselves. So especially using angle scopes, I think it's a learning curve, and initially start by just visualization like diagnostic, and then slowly you get the hang of it. It's a good thing to watch other people doing it. That's a very good way
You can
to learn.
practice on cadavers. You can practice on cadavers to get used to instruments, to get used to the need of the proper instrument at proper time.
Yeah.
That's very important.
Correct. So what I would suggest is this, that when you're using an angle scope and you go in, try not to rotate your whole hand, because then the whole image rotates. If you go in facing either at sort of 11 o'clock when you're on the right side, or 1 o'clock when you're on the left side, so that you get your orientation and you're relatively straight, And then if you want to see the maxilla, just rotate the cable so that the endoscope rotates but the camera stays straight. And that will gradually turn your picture from superior to lateral and your instrument. And then, once you get used to that, then you can come back with the instrument in front and maneuver that. Dr. Riddhi Nayak from Tripura, how long should the medical management with oral steroids or nasal spray be done before doing pre-op surgery? This may differ with polyps or with CRS.
I think it depends on the
I think this
pathology.
pre-op CT scan was answered before. So let's just say before surgery. So would you want to give pre-op steroids before surgery for polyps or for CRS?
For polyps,
See.
yes, not for CRS.
How much?
See,
How long?
Nishit.
Me?
See, Nishit. Yeah. Neelam, continue, please.
No,
Finish your answer.
finish. Me?
Neelam,
Me?
you.
Okay, sorry.
You.
Okay. I give it for 7 days. I give dexamethasone in a tapering dose. So I give it for 5 days and then ask them to taper it for 2 days. The nasal spray, usually they come to us with already using the nasal spray. But I will ask them to use a nasal spray for 2 weeks and then go for imaging.
Satish.
So, Nishit, can I ask one thing? Whether you're asking for the pre-operative maximum medical treatment or pre-operative preparation medical treatment?
Pre-op preparation medical treatment.
Okay, so for pre-operative preparation, like Neelam said, for the non-polypoidal CRS, there is no point in giving steroids. Yes, you can give antibiotics for a couple of days to minimize the inflammation. The idea is to minimize the vascularity to optimize the surgical field. But for polyps, yes, we give 7 to 10 days minimum course of steroids. Sometimes, this doesn't work for long distance patients, the patient for surgery. So, but still, you should try to give steroids for a few days to improvise your surgical field for polypoidal sinusitis.
And your choice of steroid will be?
My choice of steroid is simple prednisolone.
So I would agree with that. I would also tend to use prednisolone more than the other ones. Dr. Arvind Srivastava from Prayagraj. In recurrent polyposis, how to approach and plan the surgery. I think this is what we've just discussed already. So we'll go to the next one. The post-operative use of steroid nasal sprays in patients of nasal polyposis. This is asked by Dr. Neeru Chuk from Delhi. Post-op nasal spray.
I think she's asking nasal irrigation or spray. What is
Irrigation, both. Let's do irrigation and spray.
See, Nishit, now the goal of surgery has changed with the time. When this procedure started with the Stamberger and Messerschmitt, the idea is to establish the ventilation and drainage and expect the mucosal disease to revert back to normal. But what happened? Thousands of surgeries were done and again the polyps coming out. So ultimately, a lot of people went into research what exactly is happening and turned out to be an inflammatory disease. Immunity related disease, and the treatment is steroids. Only thing which work is a steroid. The entire cascade of events in the CRS, everything at every level, the only thing works is the steroid. Now, in a pre-operative scenario where the sinuses have not been opened, you are left with the choice of oral steroid only. Your topical will not penetrate deep into the sinuses. So now the goal is, in the present scenario, the goal of sinus surgery is two-pronged. One is to obviously remove the disease, remove the inflammatory load, everything. And the most important is to, make the topical steroid penetrable deep into the sinuses. So as long as the topical steroid penetrates deep into the sinuses at the right place, the disease is unlikely to recur. So now there is no rule of sprays. Sprays do not penetrate deeply into the sinuses. Whatever nasal spray we use, they do not penetrate beyond entry of 1/3 of the nasal cavity. Now, once you have opened all the sinuses, now is the luxury for the steroid to push inside and you can deeply penetrate by means of douching. So post-operatively, only douching, no role of nasal spray. You can penetrate topical steroids deep into the sinuses, yet without systemic side effects. And that is one of the most important goals for the sinus surgery now.
Neelam?
I agree with Satish. Exactly. I mean, all my patients of polyposis now get Buricot nasal douching in addition to saline nasal douching. They're asked to do this for at least a month. We haven't seen any systemic problems. Subsequently, after the follow up, after a month, I decide whether they're going to continue the budesonide nasal irrigation, depending on what the mucosa looks like, and whether I'm going to shift them to a spray. Because by that time, you have an idea whether the spray can really permeate inside or not. But definitely, post operatively, they will get both budesonide and saline.
And if you're going to use a spray post 1 month, for how long will you continue it?
That usually we tell our patients then, depending on how they are, if the patient is completely asymptomatic, then I'm going to tell them when you have symptoms, the symptoms that I tell them to watch out for is usually loss of smell. If they get a loss of smell, they're asked to use the spray again. Otherwise, it's just going to be plain and simple saline nasal douching. So anosmia or hyposmia is the one symptom that I ask them to watch out for.
What about the role of nebulizing a steroid spray as against a irrigation of steroid? Because now you get
Frankly,
these nasal nebs, these small nebulizer sprays.
I've
Satish,
never tried it, so I have no experience.
you've used it, Satish?
Not really. We are happy with the budesonide irrigation, and that is very
So
safe, convenient
I've
for the
used
patient as well.
So I've used this nasonep quite a lot, and I find it's very effective, especially in the area of the
Nasonep.
frontal and nasonep. It's like a small 30-second nebulizer, so it's just a local thing, and it sort of pushes the steroid under pressure, so it can go into more distant and superior areas than just the irrigation, and that seems to work really well, and can, in most cases, obviate the need for oral steroids post-op. Okay, we'll go to the next one from Palaniappan from Trichy. For frontal sinus surgery, what's your advice about an angulated skull-based drill for beak removal?
Yes, for the beak removal, generally you don't need angulated instrument. By and large, you can use your 0 degree. Yes, you can have a luxury of an angulated drill, which is naturally 15-degree angle from Medtronic. That's a transnasal burr. And the advantage of not only the angle for the beak is straightforward with 0 degree, and you can remove without an angulated drill. The advantage is that shaft doesn't come in the way, and you can actually keep an eye on the burr head with your endoscope in view. So, for beak removal, practically you don't need an angulated drill. For other works, yes, at the skull base, you may need angulated drill. Particularly for the beak removal, what he has asked, you can use simple 0 degree, raise your flap, and you can use a straight drill over there. Angulated is a luxury so that you can keep in your eye more pointed out on the burr.
So given the choice, would you rather use a punch as against a drill if you have the choice?
Drill is more safer, faster, and more, under control.
Are the chances of neoosteogenesis a little more with a drill vis-a-vis a punch?
See, Neelam, this issue was earlier when this draft started, modified endoscopic law draft, that the stenosis was a big issue. In 40 to 50% in the published studies was a routine. But that time, this steroid irrigation was not as routine post-operatively. Now with the steroid irrigation routinely pushed inside the sinuses and the entire area irrigated with the steroids more and more, this post-operative neoosteogenesis is much, much lesser. And you see your draft done now with the irrigation followed by post-operatively. There is hardly any neoosteogenesis and stenosis of the operated cavity. So post-operative steroid is good to reduce inflammation, to prevent all those narrowing, neoosteogenesis and everything. And it works very well.
So that is the trick to counter the heat generation of the drill. Dr. Riddhi Nayak from Tripura, if the ethmoid bulla is directly attached to the cribriform plate, Can an intact bulla technique be attempted?
Yes, yes, because I mean you're looking at the anterior wall of the bulla, which has got nothing to do with the cribriform plate. So what you're looking at is the relation of the maxillary ostium to the frontal ostium, and an intact bulla, even if it's attached to the cribriform plate, that's in no way going to prevent this part from happening. Instead, it's safer because then you know that the anterior ethmoidal artery is behind that.
Yeah, and secondly, to be very precise, this bulla can go to skull base, but it attached to the ethmoidal roof per se, not to the cribriform plate. Cribriform plate is the medial
It's
part
more
of the
medial.
ethmoidal roof and generally doesn't get attached to the cribriform. It gets attached to the ethmoidal roof, and that is a common finding. So that's not a big issue that to go behind the bulla and get it out.
So Satish, Dr. Neelam mentioned that often she does the frontal as a last step. What is your approach to the frontal, initially or later?
See, a lot of things depends upon how you get used to, but we generally do frontal first, keeping the advantage of intact bulla. So bulla as a source of orientation, rather not only bulla, middle turbinate, everything intact. Sometimes at the end of the surgery, sometimes you end up with a part of the turbinate removed, the bulla removed. So a lot of orientation, disturbs. Once you are experienced, you can go by any way. But
Right.
as a teaching tool, we always propagate with entire anatomy intact, including turbinate, bulla. You get more focused, more oriented to the, frontal sinus to reduce the complications. That's our philosophy.
So you would do what is comfortable with you, depending on pathology, the size of the bulla, etc.
Yeah. So
Dr.
whatever.
Pranita, sorry, carry on. Sorry, Satish.
Yeah. So it doesn't make any difference what the size of bulla or anything to it. Once you're doing intact bulla, you're supposed to stay anterior to it and above it to enter into the frontal. That's bulla acts as a guide, as a posterior limit to your frontal sinus opening. That's it.
Dr. Pranita from Hanamkonda, is it advisable to open all sinuses irrespective of CT scan findings? Any exceptions? So would you do a full house or tailor the surgery?
Tailor the surgery.
I assume this is CRS.
Tailor.
Tailor. Satish is going to go full house.
No, not for all patients. You have to tailor according to the pathology. But yes, in
So,
certain situations, you know what happens? Like exceptions she asked for, like you have a pathology like allergic fungal rhinosinusitis, a more severe form of chronic rhinosinusitis. See, rhinosinusitis is a big terminology now. It's not the time is for the pathology specific sinusitis. It could be allergic fungal sinusitis, it could be aspirin exaggerated respiratory disease, it could be any other form of severe sinusitis. Now you have any unilateral disease involving one or two sinuses, and in these extensive pathologies your steroid irrigation has a big role post operatively. So even if your one or two sinus is not spared, you can do a full house phase in those extreme situations. Otherwise, for a single sinus involved, like Neelam said, tailored, if your maxillary sinus is affected, giving symptoms again and again, you have a isolated sphenoid sinus fungus, isolated frontal disease, why to spoil other sinuses unnecessarily?
correct.
But in extremely, mucosal disease, eosinophilic disease, in certain forms of sinusitis, you can take a call when some sinus or a group of sinuses are involved.
So that is why I asked the earlier question of if you're going to tailor the surgery, would you not want to repeat a scan just pre-op so that you know which sinuses to operate or not operate instead of depending on a scan 4 or 5 months ago?
But Nishit, you are doing a surgery. When you're putting in your scope inside, you will also have a direct access. I mean, if you are putting on, let's say, doing a diagnostic nasal endoscopy, if you have
Let
disease
me
in
put
the
it another way, Neelam. Somebody's done a scan 5 months ago, has shown disease in XYZ sinuses. You have not asked, but somebody else has done a scope 1 month ago, which has shown disease in X and Y sinuses. Now Z is clear. So would you operate on XYZ or only on X and Y?
See, Nishit, you have done a scan 5 months ago with a generalized involvement of a unilateral or bilateral, whatever sinus is. That signifies patient eosinophilic disease. That pathophysiology is not going to change. With your medical treatment, it might have improved and you may find some disease in few sinuses, not all. But mind it, that is a generalized eosinophilic disease which may come back if your irrigation of steroid doesn't reach. You have given steroid pre-operatively and improved, but post-operatively you don't intend to give those steroids. So in those situations, it is better to do a full house phase and give access to the topical steroid because the underlying pathophysiology is generalized eosinophilic. A single sinus mycetoma or single sinus sinusitis is a different pathology altogether as compared to a eosinophilic disease. So we must respect the underlying disease and treat accordingly, not according to the post-treatment scan, which might have reduced the disease.
So I think
Right.
it's the to summarize, it's tailor. When you say tailor-made surgery, Nishit, I think what we are saying is it's not tailor-made to anatomy. It's a correlation of what the anatomy is and also what the underlying pathophysiology is. So it has to be tailor-made, taking both that into account.
Got it.
Yes. And see, this sinus surgery is no longer a mechanical, the treatment of sinusitis is no longer a mechanical treatment. You open up the sinuses and get a cure. Now is the time of precision medicine. So many, varieties of sinusitis have been identified with a different pathophysiologic process going on. And we must identify that particular pathophysiology going on and treat accordingly. AERD has a different pathophysiology and required a particular treatment, counseling, post-operative need of aspirin desensitization and all that. AFRS is a different pathology. So there are a number of different pathophysiologies going on and we have to treat according to that, not in a general, way treating everything
Correct.
same
So you
manner.
treat as per the etiology and not
Yes,
the
yes,
radiology.
yes, yes.
Okay. So Dr. Prashant in Udupi, little long question. If there are no polyps on endoscopy, can we classify it as a non-polyposis CRS and start medical line of treatment? Or if the same patient has mucosal thickening on CT, would you classify it as a polypoidal CRS and do surgery first?
See, polypoidal and non-polypoidal is a clinical definition, not a radiological definition. So if there are no polyps, that is non-polypoidal sinusitis. The second thing is whatever you see as a polypoidal mucosal thickening on CT. CT doesn't differentiate secretions, polyp, whatever it is. It gives the opacity. So if there are no polyps on clinical ground, it should be treated as a non-polypoidal sinusitis. As simple as that.
And Neelam, the decision to surgery will depend on history, response to medical treatment, etc., not just on a scan.
Yeah.
Okay, next is Dr. Tina from Pathanamithita. Is it a good practice to do a partial inferior turbinectomy for a better nasal douche?
No, I mean the nasal douching is supposed to go into the middle meatus. So a partial inferior turbinectomy in no way is going to ease the access of that into the area of interest. So I don't think so.
Absolutely. Totally with Neelam.
Would you consider doing a middle turbinectomy in any case of CRS
No.
Middle turbinectomy.
or partial turbinectomy?
Yes, Nishit. And this has been mentioned by, Neelam earlier to give access to the topical irrigations. Many a times your turbinate is floppy that may come post-operatively to block the ethmoidal access. And in that situation, like Neelam had shown that turbinate suturing, turbinate medialization, so many things are done. Or a partial turbinoplasty or whatever. In extensive mucosal eosinophilic disease, a partial turbinectomy is a rational approach to give access to the topical steroids post-operatively. It's a good idea so that the turbinate doesn't come in the way, fall in the ethmoids, to block the access to the topical steroid reaching to all the sinuses. So in those situations, when a turbinate creates or may create a problem, you have to deal with it. The simple example what Neelam had given, I totally agree with it about the septum as well. You know what happens? You have a simple high deviation, and sometimes you think that you can go ahead without treating this, and you can go ahead with the sinus surgery without unnecessarily touching the turbinate. You know what happens? What you generally tend to do, you shrink with a topical steroid, topical adrenaline, and it opens up. Going through the narrow area with repeated instrumentation keeps on damaging the mucosa on opposing surfaces, and that may invite synechia later on. Number one. Number two, our goal is one of the most important goal for the surgery is to give access to the topical steroids. If you don't treat that nasal septum, which may invite synechia, or if it invites synechia, it defeats the entire purpose of the surgery and may result into a failure. A simple additional process can save your patient from a revision surgery and utter failure. So
So
same
if
is
you
the
have a,
turbinate.
so I assume that you're saying that if you have a very large turbinate or very polypoidal turbinate, it's better to do a partial middle turbinectomy to improve the access to your medical
Yes.
treatment.
And you should
Neelam?
ensure that your turbinate is not going to fall in the way of the ethmoids post-operatively or not going to lateralize. Sometimes you might have, damaged the turbinate little bit, make it floppy, and it may fall laterally to block the access to the topical steroid. And better is to do a sort of partial turbinectomy to give a
Partial.
good access post-operatively.
So if
So
you
my
don't have a floppy polypoidal turbinate, it's a normal turbinate, not very large, then would you touch the turbinate, Neelam?
Not really.
no,
Not
no.
really. Rather, I would say the best way to deal with the turbinate is to respect it, not to manipulate it much. Don't do anything to it unless it bothers you.
And
And of
also,
course, you
Nishit, I
know
think
that
a
some of
point.
these patients, some of these patients may require revision surgery. However good a surgeon you are, some of those patients will still require. And then there's nothing more difficult than doing a revision polyposis surgery with no middle turbinate.
Yes.
And I think also one here needs to define what do you really mean by a large middle turbinate. So, in my opinion, any turbinate that's coming to the point where it's going to lateralize and close off your maxillary ostium opening, that would be classified as a large. So, if I'm going to have a floppy turbinate that's that long, then I would definitely like to do like a partial resection so that in the event, God forbid, even if it does lateralize, it doesn't block off the aeration, at least to the maxillary ostium. And polypoidal middle turbinate, definitely, because that is pathology.
And
You go
Nishit,
next.
what you
Sorry.
mentioned about the turbinate as a landmark in revision surgery when the previous surgeon has removed the turbinate. One simple advice not to chop the turbinate completely. We should keep the upper stump intact to give a good idea of the axilla. The entire chopping of middle turbinate is not going to help you much. Even a good partial turbinectomy inferiorly can serve the same purpose of a total turbinectomy. So there is never a need for complete chopping of the turbinate. Rather, it should be
That's very
discouraged.
important. Right. Dr. Mukherjee from Guwahati, importance of the bulla self when middle turbinate removed. Okay, so that so if the middle turbinate is removed, what is the importance of bulla? But I assume that he's taken the bulla if he's taken the middle turbinate. I mean, hopefully. Let's
Yes,
go to
yes.
an earlier question. Dr. Ranveer Singh from Sonepat. Best way to identify the anterior ethmoid artery and how do we avoid injuring it?
Scan. Read your scans properly, have an idea of where it is situated. That's about it. If you know where it is situated on the scan, once you reach that area, be very, very gentle. Don't pull anything in that area. Feel it. Use a lot of your tactile feel. I think that's what it is. It's basically read your scans well so you know where it is.
And have the scans available in the OT so you can go back and refer to it. Intra-op, Satish?
Yes. So, Nishit, I mentioned during my presentation as well. See, more the anterior ethmoidal skull base pneumatized, more the anterior ethmoidal will be prominent. Why the posterior ethmoid is not prominent? Because the posterior ethmoidal skull base through which this artery traverses is a thicker one as compared to the anterior ethmoid. That's why we see the anterioethmoidal artery, not the posterior one. Now, the commonest situation to pneumatize the anterioethmoidal skull base is a supraorbital cell. So, if you have a supraorbital cell, like Neelam said, scan, you can see on the scan, and this artery is always behind the supraorbital cell. It's a caudal structure to supraorbital cell and a more prominent one. By means of CT scan, you can gauge the situation, how difficult the artery situation can be. It is more prominent in mesentery or not. Number one. Number two, in the most difficult situation, revision situation, extensive polyposis in the vicinity of the artery, and you really want to do a complete job, then we have to take a middle path. Middle path means why we are concerned with the artery, not with the bleeding. It's not a major vessel. It's a less than a millimeter bore vessel. It's not going to bleed so profusely. The problem is the retraction laterally if it is transected, or medially it can, you can give a CSF leak. So in the most difficult situation, because why I'm saying, because we do a lot of skull based procedures transecting the artery. So transecting is not giving a big complication. So in the most difficult situation, you're walking in the vicinity of the anterioethmoidal artery, take the middle path. Middle path means your lateral limit orbit, your medial limit middle turbinate, and stay in the midline and work there with your debrider tool, whatever. Even if you injure your artery, you can bipolarize it immediately. That's it. Or coagulate it without giving any complication. So in those
Correct.
situations, you have to be careful.
So generally, if you're gentle with your instrumentation, you tend to puncture it, not transect it, in which case it's easier to coagulate it. And of course, Satish has already said, if you want to transect it, then what are the steps to take to do it? So I just want to say thank you again to our special speakers, Dr. Neelam Vaid and Dr. Satish Kumar Jain, for sparing their time and giving us some absolutely fantastic talks today. And we hope that the audience enjoyed their sharing of their wealth of knowledge with us.
A big round of applause to Nishit for
No, no.
the.
Moderating
As
us, na?
Mohan sir has mentioned in the beginning that the wise man is going to compare, going to moderate. So you have proven.
He needs
You went
special
without your.
congrats, Satish. He's moderated you and me together.
On behalf of IAOHNS, I would like to place my sincere thanks to both the speakers for their exceptional talk, and also to the moderator in this live webinar session on Mastering Endoscopic Sinus Surgery Part 1, which was almost, I think, 2.5 hours has passed, which was actually planned for 1.5 hours. Amazing. And also, I would like to thank all the participants who are nearly more than 1,000. I'm sure all the audience must have been glued to their chair, and questions will keep on coming. And we have to close the session because of time constraint. We'd like to thank the above team who made this possible. And the next program is going to be on extended endoscopic sinus surgery. And I'm sure it will be give us another dimension to this endoscopic sinus surgery. And we will communicate with you the future date. And I would like to welcome all the participants for that program too. Thank you all. Good night.
Thank you. Thank you.
Thank you, everyone.
Thank you.